Good afternoon, everyone. Namaskar and welcome to this Nitte Anaesthesia Education Series. We are online. We have with us today Dr. Ramasubramaniam from MGM Healthcare Chennai, Dr. Sanish PJ from Trivandrum, Dr. Kanakaraj again from Chennai, and we have two well-read residents, Dr. Harshita and Dr. Madhumita, to discuss the case, and Dr. Ravindra, US, is going to join us from Brunei. I welcome all of you and my colleagues, our organizing secretary, Dr. Sumalata, Dr. Joylin, Dr. Murali Shankar, my fellow faculty and residents, and all the viewers of this program. And now I call upon Dr. Joylin, our associate professor, to welcome the gathering and take the proceedings. Over to you, Dr. Joylin.
Hello and wishing everyone a warm welcome who joined us this afternoon for Nitte Anaesthesia Education Series, Chapter 7. I'm Dr. Joylin, faculty at K.S. Hegde Medical College, Department of Anesthesia. Moving forward with this unique series of anesthesia academic program targeted to all in the field of anesthesia, especially so for those preparing for their post-graduation exams. The emphasis being on relevant physiology as a masterclass by the best in the field, a case presentation moderated by experts, and features of an equipment for the month with clinical pearls. So today for our physiology masterclass, we are privileged to have Dr. Ramasubramaniam with us. He's a senior consultant from MGM Healthcare. He pursued his post-graduation at PGH and the Greenwich. Fellow Anesthesiology at Institute. Welcome, sir. Guiding us on cardiac electrophysiology and breaking down the conduction system of the heart and electrocardiogram. Following this, we have a case presentation on a patient with the pacemaker in situ coming for incidental surgeries. The case will be presented by Dr. Komal R. Deshpande and Dr. Harshita MG, who are junior residents at ESI Postgraduate Institute of Medical Sciences and Research, Bangalore. The session will be moderated by Dr. Kanakarajan, senior consultant at Department of Cardiac Anesthesia, Madras Medical Mission, Chennai, and Dr. Sanish PJ, senior consultant anesthesia at Anantapuri Hospital and Research Institute, Trivandrum, Kerala. Welcome you all, sir. And we have the equipment for the month, that is fiber optic scope, which will be taught to us by none other than Dr. Ravindra US, who will be joining us from Jirudong Park Medical Center, Brunei, where he is the consultant anesthesiologist. Sir was formerly professor and HOD in our department at K.S. Hegde, having unparalleled experience in teaching and training medical and paramedical professionals. We are looking forward to listening to you, sir. Once again, a very warm welcome to all who have joined this webinar. And now I request Dr. Ramasubramaniam to start the session.
Thank you, ma'am. Good afternoon, one and all. I am Dr. Ram, Senior Consultant from the Institute of Heart and Lung Transplant, MGM Healthcare, Chennai. As part of this continuing medical education, I would like to brief you today on the physiology of conduction in the heart and on electrocardiography. Am I audible to all? Am I clear?
Yes, sir. Yes, sir. You are very clear. Please go on, sir.
You are audible, sir. Yeah, thank you. We know that heart is the center of the circulatory system. It has a generator which generates the electrical impulse, and it has got the electrical circuit which results in propagation of these electrical impulses in an orderly sequence through the atria and through the ventricles. So looking at the anatomy of the conduction system of the heart, we have the sinus node or the sinoatrial node, which is located at the junction of the SVC and the right atrium. The impulses which originates from the sinus node travels through the interatrial pathways. They reach the atrioventricular node, which is located at the top portion of the interventricular septum. From the AV node, the electrical impulses are conducted through the bundle of His, the right and the left branches of the bundle of His, and from there they reach the Purkinje fibers. From the Purkinje fibers, the impulses, they traverse through the ventricular muscle fibers or through the ventricular myocardium, and then they are conducted to the epicardium. So coming to the basic electrophysiology, we have different types of cells within the heart. They are the muscle cells, the conducting cells, which are specialized in conduction, and the pacemaking cells, which are capable of generating the impulses of their own. The action potential of these cells are different from one another. We know that all cells are polarized with the inside of the cell more negative than outside. That is, the resting membrane potential of most of the cells are maintained around minus 90 millivolts. That is, the inside of the cell more negative compared to the outside. This is basically due to difference in the concentration of electrolytes like sodium, potassium, and calcium within and outside the cell. The movement of ions into and out of these membrane is controlled by the voltage gated channels, which will actually result in shift in the membrane potentials, like from minus 90 millivolts, minus 70, then it elicits an action potential which reaches 0 millivolts, and it may overshoot to the positive side also. So that is how it happens. So coming to the action potential of a ventricular muscle cell, normally we have a plateau phase 4, which is actually the quiet phase of the resting potential, which is around minus 90 millivolts. So when an electrical impulse reaches the muscle, the resting membrane potential becomes less negative. That is, from minus 90 millivolts, slowly it reaches to like minus 70, minus 60, like that. When it reaches the threshold potential, which is capable enough of eliciting an action potential, it shoots towards the more positive side. So from minus 90 millivolts in a ventricular muscle cell, it may reach to like plus 20, plus 30 millivolts. Then again, it drops down to the baseline of 0 millivolts. Then once again, it returns to the resting potential of minus 90 millivolts. This is what happens in a ventricular muscle cell. When we see the action potential of a pacemaking cell, like a sinus node cell, here the resting membrane potential does not stay around minus 90 millivolts. It is less negative when compared to the muscle cell. It remains at minus 60 millivolts, something like that. And what happens is they have a special characteristic feature called a slow spontaneous depolarization. That is, even at minus 60 millivolts, there is a slow depolarization, which again shifts the resting membrane potential from minus 60 to less negative side, like minus 40 millivolts. After that, this reaches well enough to elicit an action potential, and then you have the action potential being generated. So now let us look into the physiology of how this happens. That is regarding the movement of ions in and out of the membrane. When we take a muscle cell, as I told you before, the resting membrane potential is maintained around minus 90 millivolts. This is because of the sodium-potassium pump. This sodium-potassium pump actually pumps 3 sodium outside the cell in exchange for 2 potassium, which is being pumped into the cell. Plus, there are negatively charged proteins inside the cell. Because of their molecular size, they are not able to diffuse out of the cell. As a result of which, the resting membrane potential is maintained in a negative side, around minus 90 millivolts. So when an electrical impulse travels and when a depolarization is happening, which is the phase 0 of the action potential, there is a rapid upstroke of the membrane potential from minus 90 millivolts. It reaches to 0 and then to 10 to plus 20 or plus 30 millivolts. Then you have the phase 1, which is the early rapid repolarization, a phase 2, which is a plateau phase. Then you have a ventricular repolarization, which is the phase 3. And again, the resting membrane potential comes to phase 4, which is the minus 90 millivolts. That is the resting state. So how these phases happens? Phase 0 is actually contributed by opening of the fast sodium channels. Actually, there are 2 channels operating here. One is the sodium, the other one is the calcium channels. But mainly, the phase 0 is contributed by the fast sodium channels. Phase 1 is actually a repolarization phase. So this happens because of closure of the fast sodium channels, and there is a little potassium efflux also. In phase 3, as I told you before, in phase 0, the calcium channels are also contributing to phase 0, and they continue to remain so in phase 2. So there is a calcium entry in phase 2, plus there is a potassium exit. The balance between the calcium entry and the potassium exit actually determines the phase 2, which is the plateau phase. In phase 3, you have inactivation of the calcium channels with continuing potassium efflux, so which contributes to downslope of the action potential, that is the phase 3. And in phase 4, that is the resting state, which is determined by the movement of the potassium channels into and out of the membrane. Once they reach an equilibrium, the membrane potential remains at minus 90 millivolts. So this is the basic electrophysiology of a ventricular muscle cell. When we see the electrophysiology of a pacemaking cell, that is a sinus node cell, the resting membrane potential remains at minus 60 millivolts. It is not minus 90. It is actually towards a less negative side. And in phase 4, they have a characteristic feature called a slow, spontaneous diastolic depolarization. So what happens is, because of the slow sodium current, there is a depolarization and the resting membrane potential still becomes less negative. So they are very easily capable of eliciting an action potential. But if you see the characteristic feature of the action potential curve in a pacemaking cell, it does not have a rapid upstroke. The upstroke is slow. The peak is also blunted. So this is the characteristic feature. It has a slower rise, it has a less steep peak, and it has a lower overshoot. And as I told you before, the phase 0, which is contributed by the fast sodium channels in case of a ventricular muscle cell, is replaced by the calcium channels in pacemaking cell. That is why the characteristic of the action potential in a pacemaking cell is like this, with a slower rise, with a slower peak. So this is the basic electrophysiology as to how action potentials are happening in the ventricular muscle cell and in the pacemaking cell. Then coming to the repolarization and the refractory period. So phase 0 is depolarization, after which starts the repolarization phases. So you have the phase 1, a rapid repolarization, phase 2, a plateau phase, phase 3, early ventricular repolarization, and then it returns to the baseline of minus 90 millivolts, which is the resting membrane potential. So except for the phase 0, which is the depolarization phase, from phases 1 to phase 3, we have the repolarization phases. The refractory period is the period during which a cell which has been depolarized before and which is slowly getting repolarized is not able to further trigger an action potential. So if you see this characteristic curve, the repolarization and the refractory period of the action potential, there is a period called as an absolute refractory period, especially in the phases 1 and 2, where the cells are not capable of eliciting an action potential even when a secondary impulse comes. Then you have a phase between 2 and 3, which is an effective refractory period, in which phase also the cell is not able to trigger an action potential. So as we come down the lower part of the phase 3, the later part of the phase 3, and during the phase 4, the cells are in a relative refractory period or a supernormal period, where when a new impulse reaches, they are able to elicit an action potential or trigger an action potential. So this is the basic electrophysiology as to how an action potential is generated within the cardiac muscle cells. It could be a ventricular cell, it could be a muscle cell, or it could be a pacemaking cell. So now let us see how these action potentials or how these electrical impulses are conducted to the different parts. So as I told you before, the sinus node, which is the pacemaking cell, it is called the pacemaker of the heart because it has got the fastest rate of discharge. So the impulses which are originating from the sinus node, as they travel through the atria, when they activate the atrium, we have the deflections in the ECG, which is reflected as a P wave. As such, any impulse produced by the SA node does not produce any reflection in the ECG or does not produce any deflection in the ECG. Only when these impulses activate the atrium, the P waves are produced. So we have two halves of the P wave. One is the initial half and one is the later half. The initial half of the P wave is due to activation of the right atrium, and the later half or the terminal half of the P wave is because of activation of the left atrium. Coming to the atrial depolarization and repolarization phases, the atrial depolarization and repolarization happens in a circumferential manner. For example, an impulse which is originating in the sinus node travels circumferentially through the atria. As the impulse is traveling, it carries a positive charge in front and it carries a negative charge behind. That is why...
Dr. Ram?
Yeah, tell me, sir.
Sorry to interrupt. There is an echo. I don't know from where it is coming.
Sorry. Is it okay now or some disturbance is still there? Shall I proceed, sir?
Yes,
It is
sir.
still coming.
It carries a positive charge in front and it carries a negative charge behind. That is why... Yeah, tell me, sir. I think my audio is coming behind. I could hear the audio now after stopping my presentation. Sorry.
There is a delay in that audio and it is again coming.
Yes, sir. Yes, sir. I don't know why.
Is
Can I
that
proceed to again?
earphone?
No, ma'am. No, ma'am.
I think it would be better if there's a earphone, less of delay.
I think my audio is coming behind. I could hear the audio now.
No, sir. Audio was coming. Once you stopped, that one become more clearer.
Sir, no, sir. Actually, this is the one which I was speaking before. I think my voice is lagging behind. I don't know why.
No, we can hear you twice. We can hear you twice.
Okay.
Sripad,
No, I have stopped my
is there a
presentation
browser
now.
working on your computer?
No, sir. No, sir.
YouTube Live?
No, sir. Everything is off only.
No, sir. Audio was
I'm
coming.
checking with Sripad, sir.
Okay. No, sir. Actually, this is the one which I was...
Sripad, I cannot hear the echo, Sripad.
No, some echo is there, ma'am. I could also hear.
Now it is there.
I think if someone is watching the YouTube also, along with the Zoom meeting, there will be echo.
Okay, okay. I'm not doing anything on my net, sir, apart from what I'm presenting.
Sripad, sir, is anyone
Other people's can be muted, I think, sir.
Sripad, sir, just check whether other people are muted or not. If they're not, you mute it yourself from your side.
I'm not finding anybody unmute. Everybody is muted.
I'm unmute. Can you see it?
I'm not doing anything on my net, sir, apart from what I'm presenting. Sir, shall I proceed now or? Other people can be muted, I think, sir.
Yeah, I'm trying to mute those who are not. Yeah.
Sorry, sir. Some people must have kept their not realized that.
Dr. Ayushi, you may please mute. Dr. Ayushi.
Huh.
Yeah, I think everybody else is muted.
Sir, shall I proceed now?
Yes, sir. Yes, sir. Please go on, sir. But problem is not solved yet.
Yeah, problem is not solved.
Yeah, I'm trying to mute those who are not.
If it's possible, sir, it would be better if you could try with the earphone if it's available there itself.
Dr. Ayushi, you may please mute. Dr. Ayushi. Yes, she is muted.
Sir, it is your echo also again. I mean, I don't know.
Yes,
Some problem is there.
I think everybody else is muted. Yes, sir. Yes, sir. Please. The problem is not solved yet.
Yeah, problem is not solved.
If it's possible, sir, it would be better if you could try with the earphone if it's available there itself.
Earphone I don't have now, ma'am. Sir, it is your echo also again. I don't know. Some problem is there. shall I start again?
Yes, sir. Please go on, sir.
Atrial depolarization and the repolarization stages. The sinus node, the impulses originating from the sinus node, they travel in a circumferential manner to the atria. So as these impulses travels forward, they carry a positive charge in front, leaving a negative charge behind. So any exploring or active electrode which is in front of the traveling impulse will show a positive deflection, which is seen as a P wave here. The repolarization of the atria also proceeds in the circumferential manner and they proceed in the same direction. But as the repolarization wave travels, it carries a negative charge in front. That is why the repolarization of the atria is seen as a negative deflection here, which is the TA wave, the repolarization of the atrium. But usually it is not seen in the ECG because it gets buried within the QRS complex. So the impulses, after traversing through the atria, they reach the atrioventricular node. From there, they reach the bundle of His, the right and the left bundle branches, and they reach the Purkinje fibers. But no electrical activity is recorded in the ECG as the impulse traverses through the AV node, the His bundle, bundle branches, fascicles, and the Purkinje fibers. So from the Purkinje fibers, the electrical impulses will traverse through the myocardium, that is from the endocardium, myocardium, and to the epicardium. So when these impulses travel, they produce the electrical deflection in the ECG, producing the QRS complex. The QRS complex represents simultaneous activation of both ventricles. And this is how the sequence of ventricular activation happens. Initially, there is depolarization of the septum from left to right. After that, there is activation of the free walls of the ventricles. And finally, there is activation of the posterior-basal portion of the septum and the outflow tract. So the first activation is the septal activation from left to right. So as it proceeds towards right, that is noted as a positive deflection in the right-sided leads. You see the positive deflection in V1. And since it is proceeding away from the left-sided leads, which is V5 and V6, we note a negative deflection here. The next one is activation of the free wall. So as the free wall gets activated, there will be a positive deflection in the corresponding leads. For example, we see a positive deflection in V5 here. So the ventricular depolarization and repolarization actually happens in the opposite directions. So this is the endocardium where the Purkinje fibers lie. From there, the electrical impulses traverse through the myocardium and they reach the endocardium. So the electrical impulses during depolarization, they travel from the endocardium to the epicardium. So when an exploring electrode or an active electrode is present here, it is noted as a positive deflection in the ECG. But when the repolarization phase happens, this repolarization proceeds from the epicardium to the endocardium. So as these electrical impulses travel, when they travel in the forward arrow, they carry the positive charges. So behind they carry the negative charges. So as they are going away from the active electrode, again the positive deflection is noted. So in an atrial depolarization and repolarization, you see that the electrical impulses are traveling in the same direction. That is why you have a positive deflection during depolarization and a negative deflection during repolarization. This is what I told you now. P wave is the positive and TA is the negative deflection. But in case of a ventricular activation, the depolarization travels in one direction and the repolarization travels in the opposite direction. So you note both the QRS complex as well as the T wave towards the positive side. So the repolarization of the ventricles comprises of, again, the J point, which is the junction between the S and the T. You have the ST segment and you have the T wave. So this completes the repolarization phases of the ventricles. And this is a chart showing the conduction speeds in the cardiac tissue. The conduction in the Purkinje system is the fastest, which is at a rate of 4 meters per second. So now we have briefly discussed about how the impulses originate, how the impulses are conducted and regarding the basic electrophysiology of the muscles in the heart. Now we are going to see how it is recorded as electrocardiography. So the algebraic sum of the action potentials of the myocardial fibers is recorded during the cardiac cycle, and that is called electrocardiography, recording of the electrical activity of the heart. You have two types of recording. One is called the bipolar recording and one is called the unipolar recording. For example, you have a lead. Lead is nothing but an imaginary line joining two electrodes. For example, you have the right arm, you have the left arm. So an imaginary line connecting these two electrodes is called lead. So this is lead 1. In case of a bipolar lead, both the negative as well as the positive electrode will contribute to the deflection in the ECG. That is why it is called the bipolar lead. The bipolar leads are lead 1, lead 2, which is between the right arm and the left leg, and lead 3, which is between the left arm and the left leg. So in lead 2 and lead 3, the left leg is designated as positive, the arm lead is negative. In case of lead 1, the right arm is negative and the left arm carries a positive electrode. So when you connect all these leads, you have a triaxial reference system in the ECG. So coming to the unipolar lead, in case of a unipolar lead, for example, in this case, the AVF is the unipolar lead. Here, the exploring electrode is actually the left leg. The other electrodes are actually connected to a central terminal and they are grounded. So they do not contribute to any deflection in the ECG. Only this exploring electrode or the active electrode contributes to deflection in the ECG. So such a lead is called a unipolar lead. The augmented limb leads and the chest leads are unipolar leads. So when you have all the leads, for example, in the frontal plane, you have the limb leads and the augmented limb leads. In the horizontal plane, you have the precardial chest leads starting from V1 to V6. Thereby, we get a 12-lead ECG. So coming to calibration of an ECG paper, so this is how an ECG strip looks like. The speed of recording is 25 millimeters per second. So along the x-axis, you have the time, and along the y-axis, you have the amplitude. It is calibrated in such a way like one small square corresponds to 0.04 second in x-axis, and in height, if you see the amplitude, 1 millimeter is 0.1 millivolts. So this is how a standard ECG paper is calibrated. So coming to the different waves, intervals and segments, we already saw we have a P wave, then a PR segment, then you have the QRS complex. At the end of S, you have the J point, then you have the ST segment, and you have the T wave. A repolarization of the Purkinje fibers, which is designated as U wave. So this is the ECG. And you have different intervals like the PR interval, which is starting from the P wave to the beginning of the QRS complex. The PR segment is at the end of the P wave to the beginning of the QRS complex. The ST segment is from S to the beginning of the T wave. And you have two important intervals. One is TQ, which is actually the diastole, and QT interval, which is basically the electrical systole. So coming to how the normal waves looks like in ECG, first the P wave. The P wave is a small upright wave. It is smooth and well-rounded. To designate an ECG to be a sinus ECG, the P waves should be upright in lead 1. That is the basic feature. The normal duration of the P wave is less than 0.1 seconds and the normal amplitude is less than or equal to 0.25 millivolts. So coming to the QRS complex, it can be anything like this. And the duration of the QRS complex is from 0.06 to 0.1 seconds. Then you have the PR interval, which actually denotes the time taken for the ventricles or for the impulses to reach from the atria to the ventricles. The normal PR interval is 0.12 to 0.20 seconds. And as I told you before, the QT is actually the electrical systole. But when the heart rate is fast, You don't have a QT interval, you have a corrected QT interval, which is calculated by, you calculate the QT interval, and in the preceding RR interval, you take the RR interval and square root of the RR interval. So the corrected QT interval is QT interval divided by the square root of RR interval in seconds. So that gives the corrected QT interval. This is a very important slide which actually correlates between the transmembrane action potential and the surface ECG. As told before, the action potential has 4 phases. Phase 0, which is the depolarization phase. Phase 1, 2 and 3 are the repolarization phases, and phase 4 you have the quiet phase. The QRS complex in the ECG corresponds to phase 0. Phase 1 actually corresponds to the J point. Phase 2 or the plateau phase corresponds to the ST segment, and the T wave actually corresponds to phase 3 of the action potential. So till this, from QT we have the electrical systole. So the next phase is diastole, starting from the end of the T wave to the beginning of the QRS complex. That is the electrical diastole or phase 4 of the action potential. So another important slide is how these electrical events coincides with the mechanical events in the heart. So as we told you before, the QT interval corresponds to the electrical systole and the TQ interval corresponds to the electrical diastole. So similarly, when there is a QRS complex, the height of the R wave that marks the beginning of the mechanical systole. So the mechanical systole is marked by closure of the mitral valve. But in this phase, the aortic valve is still closed only. So you have a phase called as an isovolumic contraction phase, where the pressure increases within the ventricles, but still the aortic valve is not open. So at one point, the aortic valve opens when the pressure inside the ventricle exceeds the pressure outside the aorta. So then you have the actual ejection phase. Then after that, what happens? The aortic valve closes, but still the tricuspid and the mitral valves are open. So you have a phase called as an isovolumic relaxation phase, where there is a drop in pressure within the ventricles. Then opening of these valves will contribute to filling. So this is the mechanical systole. After that, you have the mechanical diastole phase. Now looking at the electrical axis of the heart. I told you before that we have 2 types of planes. One is the frontal plane and one is the horizontal plane. So the electrical position of the heart in the frontal plane corresponds to the axis deviation. So the normal axis of the heart is 30 to 90 degrees. So how to find the electrical axis in the heart? Suppose if we take a 12 lead ECG, we see at some points there are isophasic or isoelectric QRS complexes, which means the S wave amplitude and the R wave amplitude are equal. So those waves are isophasic. So suppose if we want to calculate the electrical axis of the heart and you have an isophasic complex or an isoelectric complex, the electrical axis is actually perpendicular to this isoelectric complex. For example, if the lead AVF is isoelectric, then the electrical axis is perpendicular to lead AVF, which is lead 1, that is 0. So the electrical axis may be 0 degree if it is showing a positive deflection, or it may be 180 degree if it is showing a negative deflection. Suppose if no isoelectric complexes are present in the ECG, then how to calculate the electrical axis? You can take any isoelectric complex or any QRS complexes which is very close to isoelectric complex, and you can calculate the electrical axis very similar to this. Or what you can do is you can take 2 perpendicular leads, for example lead 1 and lead AVF. So both these leads show a positive QRS deflection. So you calculate how much positive deflection is there, how much negative deflection is there. For example, there is a 5 positive deflection here, 5 unit, and there is a 1 unit negative deflection here. So the net actually corresponds to 4 units of positive deflection. Similarly, in lead AVF, you have a 9 unit of positive deflection. So what you do is in lead 1 and lead AVF, corresponding to the positive side, you drop some perpendiculars. For example, in lead 1, there is a 4 unit of positive deflection. So you drop a perpendicular from there. In lead AVF, there is a 9 unit of positive deflection. So you drop a perpendicular from here. So they intersect at one point. The vector corresponding to this point actually determines the electrical axis of the heart, which is equivalent to 70 degree here. So this is how you calculate the axis of the heart. Then the next one is cardiac rotation. The electrical axis of the heart in the horizontal plane is called the cardiac rotation. For example, normally when we see the precardial leads, the chest leads, V1 to V6, in V3 and V4, we see that the QRS complexes, they remain isophasic or isoelectric. That is, their amplitude, R wave and S wave, they remain same. So this is the normal rotation of the heart. Suppose when this transition zone shifts from V3 or V4 to V1 or V2, we call it as an early transition. Or if it shifts from V3 to V4 to V5 or V6, we call it as a late transition. So this is the clockwise rotation. The other one is the counterclockwise rotation. So now we have dealt with the basic electrophysiology of the heart, how an impulse travels, how the deflections are noted in the ECG, and how to calculate the electrical axis and the rotation. So let us see some basic ECG interpretations. First, coming to how to calculate the heart rate in the ECG. As I told you before, we have a strip in the ECG. When the heart rate is regular, usually we calculate the heart rate by this formula, 300 divided by the number of large boxes, or 1500 divided by the number of small boxes. So that will correspond to the heart rate in the ECG per minute. Suppose if the heart rate is irregular, what you do is you have something called as a 3-second time marker or a 6-second time marker. For example, in a 3-second time marker, for 3 seconds, you see how many QRS complexes are present within the 3 seconds. So the number of QRS complexes multiplied by 20 will give the heart rate in beats per minute if the heart rate is irregular. Similarly, if you have a 6-second time marker, you see the number of QRS complexes within the 6-second period. So that complexes into 10 will give the heart rate in beats per minute. So this is how you calculate the heart rate. So we know that the normal heart rate or a sinus heart rate is between 60 to 100 beats per minute. Sometimes you have what is called as a sinus arrhythmia. That is, the impulses, they originate from the SA node. So the P waves are normal, and these impulses are conducted normally to the ventricles, producing a normal QRS complex. But sometimes there is a variation in the heart rate, which is called the sinus arrhythmia. And this is because of phases of respiration. So what happens is during inspiration, the heart rate increases, and during expiration, the heart rate decreases. This is called as a sinus arrhythmia. The reason is during inspiration, what happens is the lung expands. So the stretch receptors in the lungs, the vagal impulses arising from the stretch receptors will actually inhibit the cardio inhibitory centers. So what happens is the sympathetic discharge gets activated. So there is an increase in heart rate during inspiration. So the reverse happens during expiration. So that is sinus arrhythmia. So this diagram actually shows some of the problems which are associated with the SA node, that is sinus node dysfunction. We already saw that the normal heart rate is between 60 to 100 beats per minute. So when the heart rate is less than 60, we term it as sinus bradycardia. You have a proper P wave which is conducted to the ventricles, reflecting as a normal QRS complex, but the rate is less than 60 per minute. Sometimes what happens is there is an inappropriate sinus bradycardia, that is, the rate is very low, and sometimes it can produce features of low cardiac output also. That is inappropriate sinus bradycardia. You have two other instances called a sinoatrial exit block and a sinus arrest. In both these examples, what happens is, see, these are all normal ECG. There is a P wave which is followed by a QRS complex. But there are no P waves, there are no QRS complexes here. That is, there is no ECG activity here, which means in sinoatrial exit block, the sinus node is able to generate an impulse. But as we already saw, the deflections are produced in the ECG only when the impulses produced by the sinus node activate the atria. So here, the sinus node produces the impulse, but it is not activating the atrium. There is an exit block from the sinoatrial node itself. So there is no P wave, there is no QRS complex. Whereas in sinus arrest, what happens is the sinus node itself is not producing any electrical impulse. So there is a pass here. So how to differentiate between these two? For example, if a normal wave has happened here, the preceding PP interval will have the same intervals here also. Whereas in a sinus arrest, it is not the same. The compensatory pass is different here. Then coming to the junctional escape rhythm. For example, when the sinus node is not able to trigger an electrical impulse, as we saw before, a patient will be alive when some other ectopic foci, they take over. So in this case, what happens is, there is an ectopic foci which has taken over. It is not a sinus one because it is not there is no P waves here. Similarly, there is no atrial activity. There is no ectopic foci from the atria also, because otherwise you would have had a P wave with some abnormal morphology. So here you have only the QRS complexes which are narrow. So the rhythm has originated somewhere from the junction. So this is called a junctional escape rhythm. And other examples of sinus node dysfunction, tachycardia, bradycardia syndrome, and chronic AF with slow ventricular rate. In this, what happens is the sinus node is not able to function. So when the sinus node is not able to function, it is taken over by again some ectopic foci. So in tachycardia, bradycardia syndrome, the ectopic foci which has taken over has got a higher rate of discharge. So they have a tachycardia. But suddenly when the ectopic foci starts functioning, there is a long compensatory pass which is followed by a normal sinus impulse. And during this feature, patient can have features of low cardiac output. Similarly, in chronic AF also, for example, when a patient is having some sinus node dysfunction, the spontaneous rescue or the spontaneous cure to the sinus node dysfunction is a chronic AF. The ectopic foci from the atria, they take over the activity. The patient will be in a chronic atrial fibrillation, but the ventricular rate is slow. Suppose when we try to cardiovert these patients, what happens is the atrial fibrillation stops, but only then the sick sinus syndrome or the manifestations of the sinus node dysfunction will come into picture. The patient will have features of low cardiac output. So these are all some ECG examples where the sinus node dysfunction is present. So coming to premature supraventricular complexes. So in this ECG, we could see that the impulses, some premature complexes are originating from the atria. They are not from the sinus node because the morphology of the P wave is different. You have a premature atrial complex here, but that normally goes through the AV node and the bundle of waves, producing a normal QRS complex also. But it can reset the rhythm of the SA node. So this is a premature atrial complex. Here also we have premature atrial complexes, but the rate of which are little faster compared to the normal premature atrial complex. See, when there are 3 or more consecutive premature complexes together, and if the rate of them is greater than 100 beats per minute, it is called as an atrial tachycardia. Similarly, when there are 3 or more multifocal premature atrial complexes, here also you have so many atrial complexes, that is 3 or more atrial complexes clubbed together, but the morphology of the P wave, you could see they are multifocal. So this is called as a multifocal atrial tachycardia. So these are all abnormal ECGs which arises because of sinus node dysfunction. Then again, you have a normal sinus tachycardia. So sinus tachycardia is when the heart rate is greater than 100 beats per minute. You have a sinus P wave. The sinus P wave is conducted to the ventricles, manifesting as a normal QRS complex. So the morphology of the P wave is upright in the leads 1 to AVF and in V3 to V6. This is a normal one, sinus tachycardia. Sometimes what happens is you can have abnormal tachycardia also, that is supraventricular tachycardia, where the tachycardia originates from above at the level of AV node or above the AV node, that is supraventricular tachycardia. The basic electrophysiological mechanism, how these tachycardia are produced are, one thing, that could be a re-entry pathway or an increased automaticity. See, normally, except the pacemaking cells, the other cells do not have any automaticity. But suppose if the other ectopic foci, they have an increased automaticity, they do have this phase. In phase 4, instead of the resting membrane potential being quiet, they can have a slow diastolic depolarization and they can have a spontaneous discharge. So this is increased automaticity. The last one is triggered activity, where you see some depolarizations happening in the repolarization phase, which can trigger the action potential. So all these things will lead to supraventricular tachycardia. The most important examples are atrial flutter and atrial fibrillation. So in atrial flutter, the atrial rate is very high, 300 plus or minus 50. You could see the flutter waves here with the sawtooth appearance. And this is another example of supraventricular tachycardia, where the atrial rate is very high, greater than 350 beats per minute, irregular RR intervals, because not all the P waves, are just, the atria is just fibrillating. So not all the P waves will be conducted to the ventricles. There will be definitely some block. There are irregular PR intervals. But since it is supraventricular in origin, you have a narrow QRS complexes. And as I told you, the mechanism could be either a re-entry or an ectopic foci with increased automaticity. Then coming to the junctional complex. So here what happens is, instead of the SA node being the pacemaker, you have the impulses originating from the AV node or from the junction. That is the junction of the AV node with the bundle of S. So as you could see the figures here, the impulse is originating from the junction. So these impulses will activate the ventricles in an antegrade fashion, and it can sometimes activate the atria in a retrograde fashion. Since the impulses are originating from the junction, you will have a QRS complex, which is coming here normally. But since the atria are activated retrogradely, you can have abnormal morphology of the P waves, like inverted P waves. They could be staying very close to the QRS complex because they are activated in a retrograde way. Sometimes what happens is the atrial activation proceeds next to activation of the ventricles. So you have a QRS complex, which is followed by a P wave. The atrial activation occurs next to the ventricular activation. Sometimes both the atria and the ventricles may be activated simultaneously. So the P waves get buried. So you get only the QRS complex. This is an accelerated junctional rhythm. For example, suppose if the rhythm is junctional, it is originating from the junction, that is AV node with a bundle of its junction. The rate of automaticity is just 40 to 60 beats per minute for a junction. But suppose if the rate is high, then we call it as accelerated junctional rhythms. Even if the intrinsic rate is like less than 100 beats per minute, that is 60 to 100 beats per minute, you call it as accelerated junctional rhythms. Then coming to the block rhythms. So we are dealing with pathological things one by one in the conduction system. So the impulses coming from the atria has to be conducted to the ventricles through the AV node. Suppose if there is a block in the conduction of the impulses from the atria to the ventricles, we have this atrioventricular block. So there are different types of atrioventricular block. In the first degree AV block, it is basically a conduction delay. All the impulses from the atria are conducted to the ventricles, but what happens is there is a prolonged PR interval. As I told you before, the PR interval is basically the time taken for the impulses to reach from the atria to the ventricles. So there is a gradual prolongation of the PR interval. That is first degree AV block. In case of second degree AV block, type 1, here also what happens is only one single P wave is blocked. Two or more consecutive P waves, they get conducted. So here what happens is, here also the block is at the level of the AV node, intermittent block is there. There is a gradual prolongation of the PR interval, and finally you have a missed beat. One P wave gets blocked. And immediately after the block, you have a PR interval which is shortened. So you have a gradual prolongation of the PR interval. You could see the PR interval is 0.18, gradually prolonging 0.27, 0.33. Finally, there is a missed beat. After that, there is a compensatory pass, which is followed by a PR interval, which is again shorter. So this is second degree AV block type 1. In second degree atrioventricular block type 2, similarly, only one single P wave is blocked. The other P waves are conducted mostly. But here the PR intervals are fixed, they do not vary, and there is no prolonging or shortening after the pass. But here there will be invariably some bundle branch block. That is, one branch of the bundle is intermittently blocked. That is the reason here. So the QRS complexes will be wide. So one single wave is blocked, all other waves are getting conducted, and following the block, you do not have either prolongation of the PR interval or shortening of the PR interval. And since there is a bundle branch block associated with it, the QRS complexes are wide. So coming to the third degree block or a complete heart block. So here what happens is the impulses from the atria, they are not reaching the ventricles at all. So depending on where the block is, the other ectopic foci will take over. For example, if the block is at the level of AV node, any impulses originating from the atria cannot reach the ventricles, so the patient should collapse. But what happens? Some ectopic foci will take over. Either it could be from the junction or it could be from the ventricular ectopic. So you will have an ECG morphology similar to that. So here there is a P wave. The P waves and the QRS complex are totally unrelated. So this is actually a blocked rhythm. So if the QRS complex is narrow, it means it is a complete block, and this narrow QRS complex is contributed by some ectopic foci which is originating from the junction. Suppose if the QRS complex is wide, now you know that there is a P wave and QRS complex which are totally unrelated. So this is a complete heart block, but the QRS complex is wide. So there is a ectopic foci which is originating from the ventricles, because here both the bundle branches are blocked. So definitely there is no chance that a junctional escape rhythm can activate the ventricles. So this is third degree or a complete heart block. Then coming to bundle branch block, sometimes it may happen like only one branch of the bundle will get blocked. So depending on which branch of the bundle is blocked, for example, right bundle branch you have, and then you have the left bundle branch. The right bundle is the one which is basically supplying the right ventricle. The left bundle is the one which actually supplies the septum and which results in activation of the free wall of the left ventricle. So if you have a bundle branch block, corresponding to which side of the bundle is blocked, you have the ECG complexes. That is, V1 is actually a precardial lead, basically denoting the right ventricle. So when the right bundle is blocked, you have a delayed activation of the right ventricle. So you have an RSR pattern in the right side lead. Suppose if the left bundle branch is blocked, you have a similar morphology in the left ventricular lead. For example, lead V6, you have an RR prime pattern. This basically denotes that there is a delay in the activation of the corresponding ventricles. Then now coming to the ventricular arrhythmias. So as I told you before, sometimes what happens is there may be some ectopic foci which is arising from the ventricles. It could be just a ectopic foci. So this ectopic foci will have the morphology of a wide QRS complex because it is originating from the ventricle. It is not a sinus impulse. So it has a widened QRS complex. And this premature beat is followed by a compensatory pass. After that, you have a normal sinus impulse, a P wave followed by a narrow QRS complex. So this ventricular ectopic does not reset the rhythm of the normal conducted sinus impulse. Then coming to ventricular tachycardia, again, you could see the ventricular ECG here, ventricular pattern of ECG, where there is a wide QRS complex. So as we see here, there is a wide QRS complex. There are 3 or more consecutive premature complexes with a rate greater than 100. That is why we call it as a ventricular tachycardia. Suppose if it is greater than 30 seconds, we call it as sustained. If it is less than 30 seconds, we say it is non-sustained. And seeing the morphology also, for example, you have a ventricular tachycardia here. You have a wide QRS complex, which means the foci of excitation is from the ventricle. And you have 3 or more waves, consecutive waves, having a rate greater than 100 per minute. So it is a ventricular tachycardia. It is more than 30 seconds. So it is sustained. So it is a sustained ventricular tachycardia. And if you see the morphology of the ventricular tachycardia waves, all are very similar in morphology. So you call it as a sustained monomorphic ventricular tachycardia. So this is a case of ventricular tachycardia again, where there is a ventricular tachycardia, 3 or more consecutive waves having a ventricular morphology, that is wide QRS complex, no P waves, rate greater than 100 per minute. But if you see the morphology of the Q waves, you have a polymorphic etiology. So it is called as a polymorphic ventricular tachycardia. And when these polymorphic ventricular tachycardia is associated with a wide QT or a prolonged QT interval, we call it as Torsades points. We already saw how to calculate the QT interval. So these are all some of the ventricular abnormal rhythms. And the most deadliest one is ventricular fibrillation. So here the ventricles just fibrillate, producing hemodynamic instability, collapse in the patient, and this is an emergency condition. So this rhythm is fatal unless the patient is successfully resuscitated. So we have seen some of the basic abnormal rhythms in the ECG. Apart from the normal sinus brady, sinus tachy. We saw sinus arrhythmia, which is also a normal rhythm, where the rhythm varies with regard to phases of respiration. Then we saw some of the abnormal rhythms, that is abnormal foci of excitation from the atria, then from the junctional rhythms and from the ventricles. And we also saw blocked rhythms. ECG could be useful in the diagnosis of other conditions also. For example, in cases of coronary syndromes and case of electrolyte abnormalities. So I'm going to discuss on acute coronary syndrome, ECG variations and ECG changes in relation to hyper and hypokalemia load during our subsequent slides, and which will be the last slide also. So in case of acute coronary syndrome, you can have different changes in the ECG depending on the time duration in which the changes occurs. You can have an hyperacute T wave, you can have an ST elevation, then after that you can have the development of pathological Q waves and all. So how these changes occurs in the ECG during coronary syndrome? That is again the electrophysiology. So what happens is in acute coronary syndrome is, see, this is the normal resting membrane potential, action potential of a myocardial cell, and corresponding to it we have the normal ECG. So whenever there is an injury to the myocardium, there is a myocardial cell necrosis. So when there is a myocardial cell necrosis, what happens is the potassium ions leak outside. There is a potassium efflux. The resting membrane potential changes from minus 90 millivolts to less negative side because of the potassium efflux. It becomes like minus 60 millivolts. So what happens is the action potential of the subsequently injured myocardial cells, they become shorter, they become lesser amplitude, and they become shorter duration. The action potential of a normal myocardium is like this, whereas the action potential of the injured myocardium is like this. So there is a potential difference created between the normal myocardium and between the injured myocardial cells. So this electrical current of injury, which is happening in electrical systole, produces a current which actually shows a positive deflection towards the exploring electrode, and that is manifested as ST elevation in the corresponding ECG leads. And there is another current of injury called the diastolic current of injury. For example, again, what happens is a normal action potential, a normal ECG. When there is an injury to the myocardial cell, the resting membrane potential, as already told, shifts towards less negative side, that is minus 60 millivolts. So during diastole, what happens is, so the diastole phase is basically represented by the TQ segment in the ECG. So when there is a transmural infarct, again there is an electrical current which is created during diastole, and the direction of this current is actually away from the exploring electrode. That is why, see, suppose if this is the baseline, you see a depression in the TQ segment because it is away from the exploring electrode. So this TQ segment shows a depression. But during the next systole, the injured and the normal myocardial cells will almost try to return to the baseline. So this TQ segment depression actually is manifested as an apparent ST elevation in the ECG. If this is a transmural infarct, suppose if it is a subendocardial infarct in which the infarct is not throughout the entire length, what happens is the TQ segment is shifted up, because in case of a subendocardial infarct, the electrical current which is generated because of the diastolic injury is towards the exploring electrode. So you have a TQ elevation which is manifesting as an apparent ST depression in the ECG. So this is how the ECG manifestations are seen during acute coronary syndrome. So apart from the ST changes, you have the changes in the T waves also. I have already described, like during the depolarization phase of the ventricles, the electrical impulses will travel from the endocardium to the epicardium. So any exploring electrode which is situated here will show a positive deflection. That is a T wave. During repolarization, the electrical impulse will travel in the opposite direction. So the positive charge is left behind, and that actually shows as a T wave here. This is a normal myocardium. In case of a subendocardial ischemia, what happens is the direction of depolarization and repolarization, they are in the opposite direction, like in normal ventricles. But since the repolarization wave travels through an ischemic subendocardium, the T wave is delayed. That is why you have a tall T wave during a subendocardial infarct. Whereas in case of a transmural infarct, where the whole myocardium gets infarcted, the direction of the depolarization and repolarization is the same. That is, the repolarization also proceeds in the same direction. Similarly, the repolarization also proceeds in the same direction, but which is opposite to the one which is happening in the normal myocardium. So you have a inverted T wave in the transmural ischemia. So coming to hyperkalemia, what happens is there is an increased potassium in the extracellular space. So the ratio between the intracellular and the extracellular potassium gets changed. So what happens is, because of more potassium efflux or because of more potassium staying outside, what happens is there is a delay in the conduction, which can manifest as a delay in the P wave, a prolonged P wave, a prolonged QRS complex. Then you can have a tall T wave because of the steeper slope of the repolarization wave. So you can have a tall T wave like this. And finally, this can slowly progress to bradycardia and asystole. So very similar thing happens in hypokalemia. Hypokalemia, you have a hyperpolarization because the potassium tends to stay inside. There is a hyperpolarization. So there is a delay in the action potential. The QT interval gets prolonged, and you have abnormal waves called the U wave in hypokalemia, which is again a repolarization wave, which is seen after the T wave. Thank you.
Thank you, sir. Any questions?
I think I have extensively discussed about the ECG, and I
Yes,
try
sir.
to be very sticking to the basics of the ECG alone, like how these waves happen, how these wave travels, how the ECG deflections are noted in the acute coronary syndrome and in case of electrolyte abnormalities.
Yes, sir. Agree, sir. Could you throw some light on R-on-T phenomena and how it affects ECG conduction? Hello,
Ma'am, sorry.
can you put throw some light on R-on-T phenomena, because we keep saying that and its significance in arrhythmias?
Sorry, ma'am, I'm not able to remember that one.
Okay, sorry, sir. Shipa, sir, I don't know whether I can be heard.
Yes, Dr. Suma, I'm able to hear you. We can hear your question too.
You heard me?
Yes. Yeah, Dr. Suma was asking about R-on-T phenomenon as the R wave of subsequent beat nearest to the T wave of the previous, there is likely to degeneration of ECG into ventricular fibrillation or ventricular tachycardia. That's what is told to us. So if the interval becomes shorter, it's better to be cautious and take preventive measures to stop the ectopics.
Thank you, sir. What for the clear talk that you spoke on the electrical conduction. I was looking out whether there's any questions. Thank you. We see a lot of thank you notes, sir, in the messages, and even in the YouTube. Thank yous. Thank you for your participation in our NAES program. At this juncture, I would like to bring to your notices that we have quite a few. We are on YouTube, on Nitte YouTube, and we have got on an average more than 350 views for our last 6 NAES program, and NAES 2 has 1K views as of now. We will now go on. If there's no questions, shall we move on to the case discussion, Dr. Shripad? Shall we move on to the case discussion now?
Sorry, I was muted. I was just saying that we appreciate the presence of Amita and many other senior faculty who made us proud to present this presentation. And with that, thanks, Dr. Ram Subramaniam, for this excellent speak.
Thank you, sir.
Thank you, sir. Dr. Harshita and Dr. Komal, and the moderator, Dr. Sanish and Dr. Kanagarajan. Over to you, sir.
Hello. Am I audible?
Yes, you're audible.
Good evening to everyone present here. I am Dr. Komal Deshpande, and I am Dr. Harshita MG, second year postgraduates in ESIC Medical College, Rajajinagar, Bangalore. We hereby bring warm greetings from our Department of Anaesthesiology at ESIC Medical College. We would also like to thank the organizers of this academic session and our head of department, Dr. Prasad CJS sir, for giving us an opportunity to be a part of this forum. We'd like to begin our case discussion.
Yes, please proceed.
And our topic is patient with an implanted pacemaker coming for an incidental surgery. And the surgery he is undergoing is spinal laminectomy. We present a case of Mr. Kulkarni, a 50-year-old male who is a mason by occupation and is residing at Rajajinagar, Bangalore. And he presented with the following complaints. His presenting complaints were pain in the lower back region, which is radiating to the right thigh since 3 years. He complains of tingling and numbness in both the lower limbs since 1 year. And there is restricted movements of the back and pain on bending forward since 1 year. The history of presenting illnesses, the patient presented with complaints of lower back pain since 3 years, which was insidious in onset and gradually progressive to the present state, and this has limited his daily activities. The pain is sharp and it started in the midline, which is moderate in nature and radiating to the right leg. It aggravated on bending forwards, lifting objects, coughing, and relieved partially at rest. He complains of tingling sensation in the bilateral legs, which started 1 year ago. The patient complains of difficulty in bending forwards, and there is no bowel or bladder incontinence. There is no history of trauma, fever, and weight loss. So talking about the past history, he is a known case of systemic hypertension and was on regular medication since 5 years. Patient had earlier presented with complaints of fatigue, dizziness, syncope, and chest pain 3 years ago. And his records were reviewed and the following history was noted. The chest pain was central, constricting type, radiating to the left shoulder and exacerbated on exertion and relieved at rest. He was diagnosed with inferior wall myocardial infarction and a 3rd degree heart block, which was confirmed by reviewing his past records and through an electrocardiogram. On diagnosis of inferior wall MI, angiogram was done and he was found to have a blockage of the right coronary artery. Percutaneous coronary intervention was undertaken. Double stenting of the right coronary artery was done, and tablet aspirin 75 mg and tab clopidogrel 75 mg was initiated. Initially, for 2 weeks, a temporary pacemaker was inserted. And since the patient's heart rate persistently remained around 30 to 36 beats per minute, a permanent pacemaker was inserted. Post-insertion, there have been no episodes of chest pain, syncope, or shortness of breath. He is not a known case of diabetes mellitus, tuberculosis, asthma, or epilepsy. And there is no previous history of blood transfusions or allergies. Talking about the family history, he has no history of cardiac disease in the family and no history suggestive of sudden cardiac deaths. The drug and treatment history, patient states that he has taken 2 doses of injections in the back for pain relief 6 months ago with minimal symptomatic relief. And he has been on tab amlodipine 5 mg once a day, tablet aspirin 75 mg and atorvastatin 5 mg once a day, and tablet paracetamol 500 mg for his pain. His personal history is he is a 50-year-old married male, non-smoker. He gives history of alcohol consumption, that is 150 ml of beer once a week, and his diet is mixed, appetite is good, bowel habits are regular, and bladder is normal, and sleep is disturbed due to back pain. Coming to the pacemaker history, we have derived the history from the pacemaker manufacturer card with the patient. The pacemaker was placed in the left infraclavicular region in the subcutaneous plane over the pectoralis major muscle via the left subclavian vein approach. The date of implantation was 19th January 2019, and the mode set was DDD mode. The company of the pacemaker is St. Jude's, and the model is an enduring MRI one. It is of bipolar type, and the battery life was 10.2 millivolts, and half-life of the battery is 5 years, and the current battery status was found to be 60%. The last check of the battery was done 6 months ago. Hereby summarizing the case, he is a 50-year-old male with history of systemic hypertension who suffered an inferior wall myocardial infarction followed by a complete heart block. He is a status post permanent pacemaker insertion presented with complaints of lower back pain of radicular type and paresthesia of both the lower limbs, and this is suggestive of an intervertebral disc prolapse most probably. So coming to the general physical examination, he is a middle-aged man who is moderately built and nourished. He is conscious, cooperative, and well-oriented to time, place, and person. His height is 166 centimeters. He weighs 75 kgs with a BMI of 27. Vitals are pulse is 68 beats per minute, which is regular, of good volume, and bilateral radial pulse is equal. There is no radiofemoral delay, and it is normal in character. The blood pressure was measured as 142 by 90 millimeter of mercury, measured on the right upper arm in sitting position, and no postural hypotension. Temperature was 98.8 degrees Fahrenheit with a respiratory rate of 14 cycles per minute. It is regular and there are no signs of respiratory distress. There is no pallor, icterus, clubbing, colonychia, lymphadenopathy, pedal edema, and JVP is not raised. The spine examination, first we have done the inspection where there is no obvious spinal deformity. However, there is straightening of the lumbar lordosis present. There are no swellings or sinuses. On palpation, all intervertebral spaces are well palpable and it is non-tender. The movements of the spine, there is restricted flexion due to pain and spasm, and gait is normal. Airway examination, there is no obvious facial deformities. Mouth opening is more than 3 finger breadths. Modified Mallampati class is 2, and the temporomandibular joint mobility is normal. Thyromental distance is more than 6.5 centimeters. There are no loose teeth or missing or buck teeth. The range of movements of the neck are normal, and the sternomental distance is 14 centimeters. Proceeding to the systemic examination, we have examined the central nervous system first. His higher mental functions are found to be normal. The cranial nerves are intact and motor system examination is normal. Cardiovascular system examination, on inspection, there are no precordial pulses. Apex beat is not seen and JVP is not raised. There are no other pulsations, but there is a scar present in the left infraclavicular region. Palpation, apical impulse is felt in the left fifth intercostal space, half an inch medial to the mid-clavicular line. It is tapping in character. There is no parasternal heave, no palpable thrill, or no palpable heart sounds. On auscultation, the mitral and tricuspid area, there is S1 and S2 is heard. In the pulmonary area, P2 is heard and there is no abnormal split or murmur. In the aortic area, A2 is heard with no murmurs. In the respiratory system examination on inspection, the trachea appears central. The shape of the chest is normal. Chest wall movements are bilaterally symmetrical and there is no usage of accessory muscles of respiration. On palpation,
Sorry to interrupt. Dr.
Yes.
Komal, you are presenting, right?
Yes, sir.
Okay. If the rest of the findings are normal, we can skip those
Yes, sir.
clinical examination findings. We'll stick on to the topic proper.
Okay, sir.
Okay. My co-moderator, Dr. Kanagarajan, also has joined. Good afternoon, sir. I'm Dr. Sanish. Sir, your mic is on, sir. Your voice is not heard.
Dr. Kanakarajan, we cannot hear you, sir. No, his mic is not off.
Are you able to hear?
We can hear you, sir.
Okay, sir.
Sorry for the late joining, and good afternoon, everybody. Yes, sir.
Okay, Dr. Komal, what do you think we are discussing with this patient? Like, if such a patient comes to you for elective case, no?
Yes, sir.
So, what are your concerns upfront in this case?
So initially we have to examine the patient and first localize as to what surgery we are taking up the patient for.
Okay.
Sir, device interrogation, this is Dr. Ashita, sir. Device interrogation becomes a major part of our pre-op evaluation.
No, before coming to that, what all problems he has?
Oh, yes, sir.
He just came with a low back pain,
Yes,
came
sir.
for lumbar disc surgery, right?
Yes, sir.
So, what are his background conditions which will make him special from an anesthesiologist point of view?
Okay, sir. He's a known case of hypertension, and since he has a permanent pacemaker in situ because of his previous history of complete heart block, these are the considerations we have to take before evaluating the case for surgery.
Okay, Harshita, yeah, you can also join. Okay,
Yes,
once you find that your patient has a permanent pacemaker in situ, what
Yes,
are the
sir.
things you would like to explore and know before maybe even planning for a pacemaker interrogation, like from history of what you can do, maybe from investigation part, what you can elicit?
The history.
Why are you worried about the pacemaker?
Sir, the cause of insertion of the pacemaker, sir.
Yeah, reason for the indication is
The indication
important.
of insertion
So, what's the indication in this case?
is the complete heart block, sir.
Okay, that was in the background of an
Symptomatic
acute coronary event, right?
Yes, sir.
Or it was an independent event. How did he come to know about the complete heart block?
So we elicited from his previous records that
Okay.
he had come with a history of myocardial infarction, and an angiogram was done, and there was found blockage of the right coronary artery was found. And since his intrinsic heart rate remained bradycardic even after a temporary pacemaker, decision was taken to insert a permanent pacemaker according to class 1 indications of American Heart Association, with symptomatic bradycardia and persistently symptomatic bradycardia, and also with chronotropic intolerance. A decision to insert a permanent pacemaker was taken.
Okay, so you are lucky enough to get the documents related to the device, right?
Yes, sir.
So even without getting into the documents, what all things you can elicit from the patient, like what symptom he had during that admission? It's not like only cardiologist tells, no, that's a different thing.
Yes,
After
yes.
the insertion of the device, was he symptomatic anytime?
So he'll give symptoms of syncope, shortness of breath, chest pain.
No,
and
after pacemaker insertion.
After pacemaker insertion, there were no symptoms. No symptoms.
Okay, and does it hold any significance from an anesthesiologist point of view?
In case of device failure.
Yeah, that means he may not be pacemaker dependent, or his device is reasonably working.
Yes, sir.
Right. So now how you proceed with the history? Like, is there any situation when he had to go in for a pacemaker interrogation for any other procedure or during his follow-up visit?
So as it's a permanent pacemaker, the follow-up visitations were done once a year, sir.
Okay.
His last visitation was 6 months ago.
Okay, you are lucky enough. Okay, fine.
What
So
is that?
after admission, what all things you can do? Yes, you can get the device documents, the time of insertion, regarding the type of the device. Those things you can get.
Yes, sir. We can get the patient information card where the details of the pacemaker insertion and the mode and all the details will be mentioned. So from that, we can get to know type, the mode, the functional capabilities of the pacemaker, the battery life, the chamber pace,
Okay.
and
Fair enough.
even
So
pacemaker depend.
why are you worried from anesthesiologist point of view? What's your concern?
Pacemaker dependency will be a concern, sir.
Okay.
Then functionality of the pacemaker, the mode of the pacemaker being set,
Okay.
and the procedure being done, the surgery being done, based on the anatomical site of the surgery being done also will matter, depend.
So basically, without any intervention, whether the device, implanted device, is reasonably working well, it will not trouble you. Okay. Second, now you have to take the patient through a procedure of surgery and anesthesia, during which time there are some concerns like use of electromagnetic induction, the use of cautery and other things. Will the patient or the device sustain these additional factors?
Yes.
Correct?
Yes, sir.
Okay. So that's our intention behind probably thinking about interrogating the pacemaker, its reliability, and relating with the procedure, where exactly the surgical procedure will be done, what all devices will be used during the procedure. Those kinds of thinking should come during your preoperative evaluation, right? So
Yes.
your presentation should be focusing on those things. Like he had a history of pacemaker insertion, yes. Was it working till you take him up for a surgery? Yes. And now you think about the procedure, where exactly is the location of the incision, what are the things, incision or the surgery per se. Okay.
Yes, sir.
So what are the additional threats to the device you anticipate during the procedure, and how you plan to follow in the post-operative? So all these three phases concerns should be there when you take up a patient with a implantable cardiac implantable electronic device, CIED, right?
Yes.
Okay, fine. So the provisional diagnosis, as it is shown on the slide, is lumbar intervention vertebral disc prolapse
With radicular symptoms, and he's a known hypertensive with a status post permanent pacemaker insertion in view of a refractory complete heart block due to an inferior wall myocardial infarction, and the patient is in sinus rhythm, not in failure, and he's planned for a spinal laminectomy.
Okay, how do you want to work up this case? We'll stick on to the pacemaker part because of the shortage of time.
Yes, sir.
Okay.
I lead ECG, sir, to check upon the pacemaker dependency.
Okay. So how you will identify from the lead ECG?
We'll see the pacemaker spikes are following every QRS or P wave.
Okay. And you should have an idea on which heart rate probably the pacemaker would have been set.
Baseline heart rate, sir, so that.
Pardon? Or patient's intrinsic heart rate is much more than that. That will give you some reassurance regarding the dependency on the device. Okay. Then after the pacemaker device getting into action, how is his hemodynamics maintained? Yes. His cardiac function is okay, effort tolerance is okay. Will he tolerate hemodynamic fluctuations?
Yes.
Daily procedure. Okay.
Yes, sir.
Fine. Then you look into the pacemaker interrogation chart or the report.
Yes, manufacturer.
So, how long would you go for a pacemaker interrogation for all elective cases?
No, sir. Depending on the if it's a pacemaker, if the interrogation has been done since the last year of the surgery, I wouldn't want to take up a pre-op evaluation of it.
So what's the guideline says when you will ask for the interrogation?
If it's a permanent pacemaker, then 1 year, sir. If it's a cardioverter defibrillator, then it's 6 months.
Okay.
Then cardiac resynchronization therapy, it's 3 to 6 months.
Okay. But anytime it can change if the patient has a reason, symptomatics.
Yes.
Okay. Then how do you prepare your theater for the case?
Yes, sir. Preoperative preparation,
One
sir.
more comment is, what do you mean by that pacing burden and how it determines your pacing dependency?
So pacing dependency is how dependent the patient is on the pacemaker, sir. We'll find it out from the ECG with the pacing wave followed by every QRS or a P wave.
That is another way put is, if you have a more pacing spikes than your native beats, that is also indicates pacing dependency. You need not have every QRS or every P wave has to be followed by a pacing spike to say that it is a pacing dependency. Or if you have a pacing burden more than 40%, then you can say that it is having a pacing dependency. So it need not be completely spikes in the ECG. Yes. If it is a predominantly spikes rather than the natural beats, still you can call it as a pacing dependency.
Yes, sir.
Why do you worry about them?
So because during the surgery, in case of a supraumbilical surgeries, we might have to change the mode from a DDD mode to an asynchronous mode. So
anyhow, every pacemaker, you are going to change the asynchronous mode.
Yes,
correct?
sir.
Then why do you so much worried about this pacing dependency?
Sir, if the surgery is above the umbilicus and the patient is pacemaker dependency, we would like to change the mode, sir.
Yeah, here your worry is when it goes to the asynchronous mode, if the pacing rate is more than your asynchronous mode rate, that patient will become symptomatic.
Yes,
it is pacing dependent. That
Yes.
is why we are worried. If the patient is not a pacing dependent patient, then the pacing rate, even if it is lower, the asynchronous rate, even if it is lower than the pacing rate, he will not become symptomatic. That's why we are more particular about the pacing dependency.
Yes.
Yeah. Go ahead.
Yes, sir. So in the preoperative preparation, I would like to ensure the presence of an electrophysiologist even during the surgery, apart from the pacemaker interrogation, and also emergency equipment like the defibrillator, cardioversion, and transcutaneous pacing equipment should be checked and kept ready before the induction of anesthesia. Apart from this, a crash cart and airway equipment for resuscitation is arranged and checked for all its contents. So my anesthetic goals would be primarily to avoid any intraoperative electromagnetic interference, and we are supposed to monitor the pacemaker for any dysfunction, and it is important to maintain the heart rate, rhythm, and contractility, and also maintain an oxygen supply and demand balance. Coming to the intraoperative management proper, a continuous 5-lead ECG, pulse oximetry, capnography, and temperature monitoring is mandatory. An arterial cannula is secured under local anesthesia to measure the heart rate beat by beat. That is invasive arterial blood pressure monitoring. And since the patient has a pacemaker in situ, a bipolar cautery is preferred. The electrosurgical receiving plate must be positioned so that the current pathway does not pass through or near the pacemaker, and the return pad is kept over the left side.
Shall we quickly go through your monitoring? What information will you get from the 5-lead ECG?
Sir, the pacing rhythm we can see, sir, and if any electromagnetic disturbances is there, electrical interferences in the ECG can be known.
So you can identify if pace beats are there or pacing is working. So
Yes,
how do
sir.
you know that pace beats are actually converted into a heartbeat?
Sir, we'll have to set the mode of the ECG to pace mode and diagnostic mode, sir, to see the pace spikes in the ECG monitor.
No, my question is, how do you know that electrical activity is getting
Yes.
coupled into a mechanical activity?
So we are supposed to measure the pulse by palpatory method or manually.
Okay.
If not,
Plethysmographic pulse oximetry.
And the arterial IABP, which we are measuring.
Intra-arterial blood pressure monitoring, is it mandatory for somebody who is for this case,
Sir, as
or
there
desirable? Both are the
as
same.
okay, so as if there's an electrical interference in the ECG rhythm, disturbances are there, which can be confirmed with the beats beat-to-beat monitoring done by arterial cannula placement.
That means for every surgery, whenever patient comes with pacemaker, you would like to have an intra-arterial cannula and IBP monitoring?
So we are not sure about that aspect.
I don't think that is required for all cases.
Yeah, basically, if you find that like this kind of patient whom the pacemaker inserted because of the cardiac condition, if the last preoperative evaluation, the ventricular function has been deteriorated, or this patient is so much depending on your pacemaker, so it comes under high risk, then your invasive arterial monitoring may be preferred. Otherwise, usually your the electrical activity by leads and your mechanical activity by even the pulse oximetry plethysmography should be sufficient enough to monitor the electrical activity as well as the mechanical activity.
The decision on arterial BP monitoring is mostly dictated by the procedure per se. Suppose you are doing a neurosurgery like that, or cardiac surgery like that, or because of his background conditions, not exactly related to the pacemaker insertion. Okay. So
Okay.
just because patient has a pacemaker, need not think about arterial BP monitoring for all cases.
Yes,
Okay.
sir.
Fine. You can
And
proceed.
here one more concern would be, sir, if the surgery they are using cautery, it's advisable to use a bipolar cautery because the electromagnetic interference will be lesser with
Yes,
a bipolar.
that's again an interesting thing. Basically, a surgery and anesthesia is a teamwork. So they are also concerned about this electromagnetic interference. So we need to have a team meeting prior to the case and decide on which all additional stress factors we can avoid during the procedure. If surgeon is comfortable with the bipolar cautery, definitely yes. If it is a infraumbilical surgery and the cautery plate, as you mentioned here, is very far away, maybe in the lower limb, probably if hard pressed, they can still use a unipolar cautery. But
Yes.
Our team meeting will decide that we are going to reduce or minimize such devices as much as possible. If it's a GI surgery, they can go for a harmonic scalpel cautery like that. So it's the pre-procedure team meeting which can save you the day.
Yes, sir.
Fine. So not every procedure will have this luxury. Sometimes it will be supraumbilical, or patient's positions may be awkward, or maybe high risk of bleeding chance. Everything is there. So we have to balance the concerns depending on case-to-case basis.
Yes,
Okay.
sir.
As you mentioned, it's preferred.
Yes, sir.
Yeah. Okay. Fine.
Okay, sir.
So we're not going to the proper technique and all. So
Yes.
during intraoperatively, what else concerns you will maintain because the patient has an implanted device in situ?
Sir, our major worry would be electromagnetic interferences, sir.
Yes.
Hence, we've already stated bipolar cautery is preferred, and short bursts less than 10 seconds are preferred. Then the returning pad is placed as far as away, at least 15 centimeter below the far away from the pulse generator.
Okay, fine. Then, so you'll be watching the hemodynamics throughout. So maybe we'll also keep in mind that in case of any hemodynamic disturbance, we'll think about pacemaker dysfunction also, if it is not manipulated by reprogramming or magnet application. Okay, fine. So which all cases you would like to have a magnet coming into place?
Magnet, so if the patient is being pacemaker dependent and
Okay.
the supraumbilical surgery is planned for, we would like to use the magnet, sir, or the reprogramming of the pacemaker.
Reprogram to asynchronous mode.
Asynchronous mode of
That
the
intervention
you
should
will
be
prefer?
there. Okay.
yes,
Which
sir.
one you will prefer and why? You have both options. You have a electrophysiologist and you have a cardiac specialist who can come and reprogram your pacemaker, and you have a magnet in your own OT. So which one you prefer?
Reprogramming of the set device to the asynchronous mode, I would like to choose.
Why?
So because in our case, the accessibility, pacemaker accessibility is difficult because the patient is in a prone position for laminectomy. In such cases, we prefer reprogramming rather than using a magnet.
What is the disadvantage of using magnet?
Because it is not quickly reversible, sir, as reprogramming is not as quickly reversible as the magnet is.
Sorry, I couldn't get you.
Sir, the reprogramming of the device is not quickly reversible like that of a magnet is, sir.
So you prefer the magnet?
For this case, as the patient is in prone position, there'll be difficulties in placing the magnet. So we would like to choose with the programming of the pacemaker priorly to asynchronous.
That's what I fully accept.
Yes, sir.
But why not magnet? Because still you are saying that you can reverse it very quickly.
Yes, sir.
Position alone cannot dictate a magnet because you can easily fix it. But what I want to know is, what is the disadvantage of using a magnet?
So we have to first check if the patient, if the pacemaker is magnet response is disabled, or if the magnet has the set action on the pacemaker priorly.
So you don't know exactly
If the magnet
whether
response
all the pacemakers will go into a asynchronous mode when you apply a magnet.
Yes, sir.
Okay, so that is always there.
Yes.
Second thing is, some of the pacemakers may not have the intrinsic rate which you like to have it. So when you're reprogramming it, even you can asynchronous rate, you can modify it depending on the requirement.
Okay, sir.
Okay, right, go ahead.
So intraoperative considerations, we have to maintain normal blood pressure, normocapnia and normothermia to avoid any pacemaker dysfunction, and adequate analgesia and sedation should be provided, and extubation is done after complete recovery. So coming to the post-operative management.
Just to hold it, you told me only about the 3 numbers in the pacemaker. Suppose
Yes,
and the 4th one is also there in the pacemaker. What are the precautions you will take?
So the 4th position being the programmability, that is the rate modulation or the rate responsive, sir.
Okay.
That will also be changed to the inhibitory mode.
So what will be the problem?
So intraoperatively, if the anti-tachyarrhythmia mode is not set, so intraoperatively we want the heart rate to we want to allow certain amount of tachycardia. So if that is inhibited by the pacemaker, then physiologically we cannot compensate for the stress response of the surgery. So we have to
Especially with the physiological changes.
so increase metabolic demand, surgical stress, tachycardia.
Mainly hypovolemia.
Yes, sir, hypovolemia response. The response of tachycardia will not be seen.
That is the most important. Even in the rate adaptive, even if you don't have the rate adaptive modulation, even when you go into asynchronous mode, these patients cannot increase their heart rate when there is a hypovolemia.
Yes, sir.
We always remember that. And if you don't inhibit the rate adaptive modulation,
yes, sir,
when your minute ventilation hydrogenically high, these patients will develop tachycardia. So these 2 things you have to remember if there is a R mode is there.
Yes, sir.
And what is the disadvantage of, since it is only a pacemaker, but if you have a AECD, what is the problem in preventing an anti-tachycardia?
Anti-tachycardia mode or when disabled, sir, then they won't respond to ventricular tachycardias. Then we'll have to prep for transcutaneous pacing and cardioversion.
First shock.
Yes,
Then-
the shock defibrillator.
So that is the another additional precautions you should always have it.
Yes.
Especially these kind of cardiac patients.
Yes, sir.
Okay. Go ahead.
So coming to the post-operative management, the patient should be transferred to a cardiac care unit, and the pacemaker mode is reprogrammed by an electrophysiology team back to the previous mode, that is a DDD mode. And adequate analgesia and hydration is ensured, and vigilant ECG monitoring should be done, and availability of a backup pacing equipment is ensured. And prior to discharge from the CCU, a pacemaker interrogation may be necessary. So, hello.
So post-operatively, basically, when, how often or how quickly you have to reprogram it?
So within 24 hours, 24 to 48 hours, we'll have to reprogram.
Okay, right. Dr. Sanish?
Yes.
This,
Okay. Fine. So this is algorithm, right?
yes, sir. We have an algorithm for decision making.
Okay. So can you explain the algorithm?
So based on the type of the device, be it pacemaker or implantable cardioverter defibrillator or leadless pacemaker, based on the type, we decide on, sir, if electromagnetic interference is expected. If no, then no further intervention, nothing to do, sir. If the electromagnetic interference is expected, as in the supraumbilical surgery, then we go into a mode where if we decide if the patient is pacemaker dependent based on ECG or pacemaker interrogation. If no, then we don't have to do anything. If the patient is pacemaker dependent and we expect an electromagnetic interference, then we ensure that the electromagnetic interference, that is the electrocautery, is at least 15 centimeter away from the pulse generator. Coming to implantable cardioverter defibrillator, we see if the patient is pacemaker dependent. If yes, then we consult the CED team to reprogram the device by programming the device or by magnet placement. If no, then we'll check if the EMI is originating above the umbilicus. If no, we don't have to worry much. If yes, then we'll have to deactivate by the magnet or the programmer.
Okay. Actually, the issue comes when the patient comes for an emergency surgery.
Yes,
and you don't have a time and facility for interrogation.
Yes, sir.
Okay, that time we need to go to plan B. That also should be there. You should have a magnet available. You should be having a cardiologist consultation. May not be a device interrogation per se. So
Yes,
with that consultation, we can decide how to go about. But there is no hard and fast rule for pacemaker interrogation for all cases. Okay.
Yes, sir.
But present recommendations, it's not mandatory, but in selected cases, definitely, as you have mentioned, it is applicable. Preoperative workup is a must. But post-operatively, before you leave, the patient leaves your service area, patient should be reassured about the functionality of the device, implanted device. Okay,
Yes.
especially I am speaking about the cardioverter defibrillators and all, because that will be active once in a while only when the patient unexpectedly or paroxysmally throws a dangerous tachyarrhythmia. Okay,
Yes.
so that facility patient should be getting.
Yes, sir.
Okay, so the emergency protocol for cardiac implantable electronic devices, how we decide if the patient is pacemaker dependent?
Yes, sir. And based on the electromagnetic interference being present, that if it's in the vicinity of the pacemaker.
Okay, which all cases you think the electromagnetic interference will be applicable?
Sir, in extracorporeal shockwave lithotripsy.
Yes.
And
So
electrosurgery.
what's your plan for extracorporeal shockwave lithotripsy?
We should avoid focusing the lithotripsy beam near the pulse generator.
Okay.
And disable sensing of the pacemaker if it shows over-sensing and under-pacing.
Okay.
And terminate the procedure if any arrhythmia develops, and deactivate. The ICD should be deactivated for the procedure, sir.
Okay. Fine. So similar situations, can you mention a few more situations where we are actually worried about the implanted devices?
In radio frequency ablations for above umbilicus, or radiotherapy.
Yeah, radio frequency ablation, usually we do for the cardiac conduction system, no?
Yes.
Okay, fine. So the path of radio frequency current should be away from the pulse generator and leads as much as possible. Okay, so direct contact between ablation catheter and the pulse generator should be avoided. How about cardioversion or defibrillation in a case of a patient with pacemaker going in for a sudden cardiac collapse?
Sir, if at all the pacemaker has been reprogrammed or magnet is placed, we have to.
No, in a cardiac arrest scenario, there is no room for interrogation.
Okay.
We just feel that there is a swelling, and we may get some clues that it may be an implanted or pulse generator.
Where you will keep your pads?
Anteroposterior, sir. Anteroposterior fashion the position of.
Where you will keep the right arm?
Sir, it's placed on the left side, infraclavicular region, anteriorly, and posteriorly it's placed infrascapular region, left side. Sandwiching the heart so that there is decreased transthoracic impedance.
Right arm pad, where you will keep?
Sir?
There are two pads, no?
Yes, sir.
So right pad, where you will keep?
Sir, it should be at least 10 centimeter away from the pulse generator.
Right arm is anterior or posterior?
Sir? One of the pad is placed on the left side infraclavicularly. Anteriorly, the other pad is placed posteriorly infrascapular region.
That's what I'm asking. I think right arm should be in the posterior position and your apex will be the left arm pads. Correct?
Okay. Yes, sir.
Correct now?
Yes.
Yeah. Then remaining other two positions. One is anterior posterior.
Anterolateral, sir.
They call it as anterolateral or a different name? What they call?
Called
Apex anterior something. Correct?
Oh, yes. Yes, sir.
Apex anterior and apex. Third one. You should know the position exactly. Okay. It's very, very important because that is how you can avoid the damaging to all the electronic implantable devices. See, the most important thing is not only safeguarding the instruments. If the patient comes with the AACD, it is almost like the combo device is 8 lakh rupees. So it's a huge money also involved. Okay. So it's our responsibility to take care of the thing. And especially patient comes with the cardiac disease, the defibrillation has to be very ready and you should know exactly where you are keeping without damaging the pacemakers.
Yes, sir.
All three positions we should be well versed.
Okay, sir.
Anterior posterior is commonest use, but if due to some reason you are not able to use it, you should use it. The second point is the monitoring. We have stopped with the invasive arterial pressure monitoring. We should know about the central line also. What are the problem in putting a central venous access also? So when we are putting the central venous access, we should know where are the leads. So that is also very, very important.
Yes, sir. Pre-procedure chest X-ray is done to confirm the position of the leads.
Exactly. How will you identify AAC, the CRT or AACD through the X-ray?
Sir, double coil is present in X-ray in the leads. If it in the X-ray, if it is a cardioverter defibrillator.
Yeah, you will have some sort of black color cover.
Opaque, yes.
Opaque color, yes. Yeah. Good. So it's very, very important because before you go into the interrogations, we should have the some sort of provisional diagnosis, what type of device patient is having and what we should do.
Yes, sir.
Okay, I think one more thing, like the beauty of our specialty of anesthesia is any development in our other specialties will also affect us, be it newer insulins or newer drugs, newer generation pacemaker or implantable devices are also coming, like the leadless pacemaker and all. So we should be able to at least identify them. The thing is, when it comes to an elective case, we'll get enough and more time to do the workup, get the consultations done. But at least for emergency purpose, emergency cases or maybe late night working hours, you might get a trauma victim or a laparotomy or a craniotomy with a newer devices implanted. So I think from anesthesia point of view, we should be knowing something about the newer generation of cardiac implantable electronic devices also. So shall we wind up this session?
Yeah,
Because
see, basically now the concluding part, what I like to insist is, if you look at the number of patients getting implanted with these kind of devices, almost like a 37,000 per year. So it's highly likely that at any point of the time, we all will come across some patients coming for some procedures with these kind of implantable things. So we have to well versed with these kind of procedures, because you are going to come across very rare in these kind of patients. So you should be always thorough with how to manage these kind of patients or get a help from the experts. Thank you.
Thank you very much, sir. And I think Dr. Komal and Dr. Harshida, you did a nice job.
Yeah, they have done a good job. They really presented well and they well read. Good.
Thank you so much, sir, for giving us this opportunity.
Thank you very much. I take this opportunity to thank the organizers, Dr. Sripata, Dr. Suma, and all the organizing team for this opportunity. And thanks from my side.
Yeah. Thank you for the opportunity.
Thank you, Dr. Kanakarajan and Dr. Sanish, for joining us today. And a big applause to Harshita and Komal for a lucid presentation here.
Thank you, ma'am.
Welcome. If there are no questions, we will move on to the next session. Any questions? I couldn't find any in the chat box, Dr. Sripat. Did you see any in the?
No questions so far.
Okay.
Dr. Harshita and Dr. Komal did a wonderful job. And
Yes.
thanks, Dr. Shanish and Dr. Kanakaraj. It was very informative and lucid discussion.
Thank you, sir. Thank you very much.
Can I request all the participants to switch on their videos for a moment so that we can take a screenshot? Shipa sir, from your side, screenshot.
Yes. Yeah. Can you please put on your videos for a minute?
Can you all switch on your videos, please, for a moment? Just give us 2 minutes. We will take up some screenshots. Thank you. And now we move on to the session very interesting session in our NAES 7 equipment of the month. We have with us Dr. Ravindra sir, Ravindra Ubraka. Good evening, sir.
Good evening, Suma.
Over to you, sir. He's an expert, and you're going to hear the expert speak now.
Just opening my presentation.
Yes, sir. Yes, sir.
Just give me a minute.
Yes, yes.
Yeah. Is it seen?
No, sir. You have to share your screen.
Yeah, that's what I tried to do. 1 minute. It's not the one. Just a minute.
Good evening, Dr. Mallikarjun, sir. And
Namaskara, Suman.
Namaskar, sir. Chennagidralla?
Good. By the grace of Allah.
Hi, Dr. Malli.
Hi, Shripad.
Congratulations, your daughter.
Oh, thanks a lot.
The class. I'm not able to find where is the. I have to open it first, is it?
Yes, sir. You have to open on the desktop.
Open it somewhere. So go to share screen. In that, you go to share.
Okay.
So share screen, you see all the tabs, and you can pick the tab whichever you want. So keep this presentation open. Good evening, Sridevi madam. How are you? Good evening, Dr. Hemlata.
ಆಯ್ತಾ ಸರ್?
ಇಲ್ಲ ಒಂದು ನಿಮಿಷ ಮಾಡಿಟ್ಟದ್ದು.
ನೀವು ಡೆಸ್ಕ್ಟಾಪ್
Wait,
ಗೆ
wait.
ಪೇಸ್ಟ್ ಮಾಡಿ, ಓಪನ್ ಮಾಡಿ.
Yes.
ಓಕೆ.
Okay. I opened it.
Yes, sir.
You have to go to share screen now.
Yes,
Go
now
to
it's
share
ready. Now it's ready. Yeah, yeah.
Yes, sir.
Okay. Yeah, share screen. Yes, now it's open. Share.
Zoom. Yes,
Okay.
it's coming, sir. It's
I'm
slowly
just
coming from Brunei. Yes, we got it.
Yeah.
Full screen, sir. Yes.
Okay.
Over to you, sir.
Okay. Good evening. Thank you, Dr. Shripad and Suma and the entire team of Kshema Anesthesia for giving me an opportunity. And warm greetings from Brunei, of course, the Jeridong Park Medical Center where I'm working. This topic, I hope I'll be able to do some justice to this topic within about 15-20 minutes, focusing particularly on the equipment. This is something when you hear this name, at least in our times, we used to be excited. Fiber optic intubation, as if it's the sole panacea for everything which is difficult or which is difficult in airway management. So let us see how important it is. And in advance, few acknowledgements and just statements. One is some of the photos, as you would have already seen, are from Kshema patients. And I'm sorry, I have not completely covered the identity of the patient. Apologies for that. Probably in this era, it is more important, but some of the patients were in Kshema when I was there. Thank you for my colleagues for agreeing me to share that. And if some of my erstwhile colleagues in Kshema are seen, I hope they won't mind. So with these few words, let us go ahead with this. When you see these patients, this slide and this slide, what is common? They all have difficult airways. So their airways cannot be managed or cannot be intubated. So intubation is not airway management. It is a part of airway management. So they may not be managed by conventional techniques. Maybe a direct laryngoscope, maybe a video laryngoscope, but they do not require tracheostomy. So tracheostomy should not be something used indiscriminately. If you use tracheostomy, for example, this patient with a congenital temporomandibular joint ankylosis, it's something which is usually not acceptable unless it's an emergency. So what's the alternatives? Nowadays, the direct vision and intubation, that's the fiber optic bronchoscope, or what we call the flexible video endoscope, that's the current terminology. So now we'll just go through some of the important aspects of this equipment and the related aspects. So these are the basic advantages that it's a gold standard because it can be done awake or sedation or anesthesia in all the different ways, in different positions. Patient cooperation is important, but if anesthetized, that's not an important factor. So in different positions you can do. There are multiple ways of managing the airway with the video endoscope, flexible video endoscope, or what we commonly refer to as fiber optic bronchoscope. So this is only one of the device for difficult airway management. That is something which residents of PGs should internalize this one. It's not a one-point solution for difficult airway, but it's a very useful one. But it's the only device which passes beyond the glottis. There is no conventionally available device which passes beyond the glottis and enables you to directly visualize the complete part of the airway till the point where you would like to position the endotracheal tube tip. So there are multiple indications and multiple ways of using a fiber optic bronchoscope or a flexible video endoscope. I would prefer in most of this, for most part of my presentation, the word flexible video endoscope, except when I show the real fiber optic bronchoscope. So this is just the 5 parts of my talk: brief history and terminology, structure, components and sizes, preparation and handling, accessories little bit, and miscellaneous if there's anything I left. So this is end-on means within, looking inside, basically looking inside the body cavities, which includes the airway. And Anton Jean Desormeaux, he's considered as father of endoscopy, whereas father of bronchoscopy, which we are more concerned with, is Gustav Kilian. He demonstrated it in 1897, and 1904, the Taylor Jackson, who is also known for his contributions to tracheostomy, he developed an electric light source for the bronchoscope. Then it took nearly 6 decades or 5.5 decades for somebody to present or develop and incorporate fiber optic technology for a flexible bronchoscope. That is in principle, that is by Shigeto Ikeda. He suggested and involved Olympus to develop the first flexible bronchoscope. So Olympus is the first bronchoscope that was developed by in 1966 and presented in a conference. In 1980, the charged coupled devices, the introduction resulted in flexible video endoscope by enabling the engineers or the manufacturers to incorporate video cameras at the tip of the insertion cord, what we call, thus disposing of the need for glass fibers. So this is very brief history. So always when you learn about an instrument, especially something which is different and unique, it's good to know some historical background. So some terminologies, we commonly talk about fiber optic bronchoscope, though many people say intubation fiber scope is a better word. So is there any difference between these two? Yes, they say that the intubation fiber scope, basically the difference is, one is in the length of the insertion cord, which may be about 5 centimeters or something less than the bronchoscope, number one. Then the number of working channels, what we call, the channels which enable you to pass the instrument is fiber optic bronchoscope. And flexible video endoscope is where there's a video at the end. Instead of the optic fibers directly, the image transmission from the tip, it is the video camera which catches the image, then is transmitted to the proximal part or the monitor, and it is flexible. That's called flexible video endoscope. So the new generation of the endoscopes, flexible airway endoscopes are usually flexible. There can be some of them what we call a hybrid endoscope, where both some fibers structure is there and the video camera is also there. So flexible intubating video endoscope is the next terminology. So, but this particular terminology is somehow used by Karl Storz. Another statement is that I do not favor or recommend Karl Storz or any other company brands. Only because I'm more familiar with Karl Storz, I am using their equipment as example. That is what I have been experienced with for a very long time. So flexible intubating video endoscope is the flexible video endoscope produced by Karl Storz. So it becomes a catchy term for 5. That is 5 years, 5 years, so many extensions are there. So fiber optic guided or fiber optic aided intubation is another terminology. When you intubate using a fiber optic or a flexible video endoscope, it's commonly called fiber optic guided intubation. So then flexible video endoscopy guided intubation. Then the most important terminology, which is a more comprehensive and descriptive, covering the entire range of applications of the flexible video endoscopy in airway management, is fiber optic guided or flexible video endoscopy guided airway management techniques, which can be assessment, which can be a confirmation of placement of a supraglottic airway device, which can be something to guide tracheostomy, which can something to guide the extubation, which can be something to guide the placement of a double lumen tube, or a simple conventional intubation by maybe oral route or the nasal route, or to assist retrograde intubation, whatever it is. The common terminology is flexible video endoscope guided airway management techniques. I think we should use that technique, the terminology, more often. So basically, if you look at, these are the 4 basic components of any video endoscope: illumination system, plumbing system of the channels, image transmission system, mechanical system, angulation to move the tip. That is the mechanical part in a video endoscope. So this is just 2 pictures, the schematic pictures of the flexible video endoscope. There are different makes, from older ones to the latest one. This is somewhere the older one, and you can see the different parts. Basically, if you see the midline, if you take almost a line across these 2 pictures, somewhere around 60% length from above, the above part is called control or the handle, and the below part is called the inventional, or the distal part is called the insertion cord. So we'll see that. So in control or the body, if you see here, you have, starting from the proximal most, is the eyepiece, which is no more present in the modern endoscope. So earlier instruments, flexible or fiber optic, when they were classically fiber optic intubation scopes or fiber optic bronchoscopes, eyepiece is the one through which you visualize the image. Or through that, you can connect a camera to a monitor. So that's how we used to do early. So then next is the diopter ring, with which you can adjust the focus. So that focusing is very important, especially in the earlier equipment. The modern equipment do not need this zero balancing or focusing, etc. Okay, so now the next one is, you have various ports. See here, you have the suction port and you have the working channel or channels. So here you can see here, there's a suction channel for which there's a control suction button, which has got a one-way valve. You connect the suction to the suction port, and this is for the working channel. So through the working channel, you can pass. See, this is the working channel. This instrument here, you can see only one working channel. It has got a proximal opening in the control or the handle or the body, and the distal opening in the tip. So, and then you have a control lever. We'll see more about that as we move on. And there's a cable for light source. for image processing. So these are the components. So there is some arrangement to visualize, some arrangement to focus, some arrangement to suck out the secretions, and some arrangements to pass or administer drugs or pass certain equipment, etc. So all these arranged in a flexible and compact way so that you can manipulate easily in the narrow passage, what we call the airway. So that is how the equipment is organized. Of course, the modifications we'll see in subsequent pictures. So this is not true for all the modern scopes. There are minor modifications, but broader structure is this. The two parts and each divided into further. So we'll see now a little more details about the parts. So here, if you see the proximal part, the eyepiece and the diopter ring, here you can see the diopter ring. Then the lights, how they differ, you see in the old scope and the modern scope. So here, this modern scope it's quite interesting. Like you can take a screenshot, you can make a video recording. So many things are possible with your fingertip, the same finger which controls the suction button. You can attach the suction button here. This is for the suction button or suction control we can call. So the same finger can be used to control this. And usually the thumb is used to control the control lever movement. And this is for the working channel. And when you bend, this is the tip of the, what you can notice is the distal most part is 10 centimeters, remaining all, it is marked at 5 centimeters measurement. So that is just, and here this is a portable light source. So that means your equipment becomes more portable. So for emergency of the hospital, away from the pre-hospital management also, such equipment can be used. So this is for connecting to the monitor. This is again from, this is the flexible intubating video endoscope, the 5, where this can be connected to CMAC monitor. So now if you see, the insertion cord is the next part. So again, we'll come back to the control when we go to the way we use the equipment. When you say the insertion cord, it's a thin, narrow cord, which can be very delicate if it is a fiber optic and not so delicate if it is a non-fiber optic. Length of about 55 to 60 centimeters, marking at every 5 centimeters, except in the distal 10 centimeter, contains the image and light transmission bundle, channels, and angulated tip. So these are the contents of the insertion cord, the image and light transmission bundles, and the channels, which may vary from 1 to 3 or 0 also. If you go for a very small size, the endoscope like this, they may not have any suction channel also. And diameter of the channels, this is the size of the scope. Diameter of the channel you'll see later. The size of the scope, which is the diameter of the insertion cord, is, it varies from 2.2 for very small size endotracheal tube, or maybe 1.8 also I heard it's available for a endotracheal tube of 2.5 and 6.5 millimeters, especially for ICU they have developed now. So it's a big one where you can pass a tube of 8 size also, and 7.5 or 8. So proximally junction with the control body, this is very important statement. Proximally, the junction with the control body and distally the tip are the two and the only two movable parts of the endoscope. You should not bend at any other part of the endoscope that is likely to damage the most valuable or precious equipment your department might be owning. So that's very important. And the junction between the control, this part is the easily fatigable, or it's more prone for damage. There are certain mechanisms which protect it from easy damage or decrease the vulnerability to damage. So there is no sideward movement of the bronchoscope. You cannot twist it by other than rotating your hand itself, or at the wrist you rotate the scope. But per se inside the scope there is no sideward movement, only backward and forward movement. Okay, so in classical fiber optic flexible bronchoscopes, okay, the image transmission is by cohesive image transmission fibers and light transmission by non-cohesive. That's why they are called. And cladding is the term used to keep them in order. the small, very thin hair-like or still smaller glass fibers, they have to be maintained in a very systematic order. So some of the terminals used are cladding, etc. And then image transmission takes place through the mechanism by which the image transmission takes place in the fiber optic bronchoscopy is called total internal reflection. So I am not going to explain you this, and I am not a very good person in physics. That's one of my Achilles heels, you can say. So you can go through this, and those who have a special interest in physics can understand it better. So these are the, but you must know these terminologies like cladding, then the light transmission, all these things, no, the total internal reflection, etc. It's good to know when you use a equipment as complicated as this or as useful as a flexible video endoscope. So now coming further down, like no, more into the insertion cord. Glass fibers are absent when you talk about the flexible video endoscope. Image transmission takes place from the charged coupled devices, a lens assembly and electronic silicon chip, and video camera at the tip. So there may be 1 to 3 channels, diameters varying from of the channels. This is the diameters of the channels. So if you have to pass some instruments or take some malleolar lavage or something, especially in the ICU, the breast biopsy, etc., you need a wider working channel. So it can vary from 0.4. When it is 0.4 or little more than that, you might be able to do only insertion of a epidural catheter, or you might be able to inject the drugs. I hope I'm okay, like I'm not very fast nor very slow. Okay. So distal portion is the tip. So distal beyond that angulation part, it can be moved in anterior posterior direction with angulated wires. Angulated wires is what controls, which is not seen. It controls that bending mechanism, how much it can bend and how it can bend. So it's also called up and down or anterior posterior direction. Deflection angle, how much it can move forward, and the angulation anterior and posterior varies among different makes and different sizes. I'll come to that later. So the tip contains the opening of the channels and the CCD video camera devices. So miniaturized nanotechnology has come into medicine in a big way, and this is one of the applications. If you look at the complete assembly of the video endoscope or a fiber optic bronchoscope, this is how you can schematically represent, whether it's a light source, video processor, video scope, all these things, no, they all vary now depending on the modern technology, and each company will develop their own patented technology, which I am not going into. You can visit the company website for more information. So what modifications have taken place? The handle or the control or the body, replacement of the eyepiece with a directly connection to the monitor, recording facilities, portable light source, integrated monitor. So these are some of the, some of the monitors are directly attached to the pocket monitors are available. You can directly attach to the place where the eyepiece is there. And the insertion cord is the CCD video camera and becoming non-fiber optic, and such a like nice channels incorporating into that. So, and reusable to disposable. And I have not spoken much about the monitors. These monitors, it's a multifunctional monitor. The beauty of especially CMAC is that it produces high definition images, and you can easily switch over from one airway equipment viewing device. There are 2 viewing devices. One is the video laryngoscope, other one is flexible endoscope. So if one fails, you can switch over to other or plan B, plan A to plan B seamlessly, what we call, and you can record, you can visualize, everything is possible, and it's very sturdy also. So this is CMAC. Similarly, other monitors also available. I'm not sure about the flexible video endoscope. Otherwise, for video laryngoscope, wireless monitors are also available. So then this one, there's one 5S and one 5.6.5. They look almost similar, very elegant looking. The 5S is for single use, and 5.6.5 is an extra large scope, particularly developed for ICU with wide working channel permitting alveolar lavage. So if you work in a place where money is not a problem, your department has 5 or 6 endoscopes, then you have a responsibility to choose the most appropriate one. Or alternately, if you have single scope or 2 scopes, you have a responsibility to select a proper technique to suit the size of the endoscope what you have. So you have to choose depending on what is available to you. You can't say that I don't have this, or just try to make the best use of equipment in your department. And this is a new concept which is probably less about 10 years in India, not more than that, or maybe 12 years, AMBU scope. This is the first disposable scope, and they developed for military purpose also in the conflict anesthesia. That's now in the war field and all. You can use this and dispose it off, but they say you can change this portion, the insertion cord portion, up to 40 times they use, and a very good monitor also they have. So earlier it was just a insertion cord and a control lever. So now they have the suction port and the oxygen port also has been have been incorporated to this AMBU scope. So now comes the preparation and handling of the video endoscope. I think I'll take another 5 to 7 minutes. I hope it's fine. So size selection is the first thing. If you have more than one size, sterility, integrity of the scope. In these steps, in this sequence, first select a size, ensure that it's sterile. Next, ensure that its integrity is not breached. Just like our integrity should not be breached, the equipment also has got integrity. So human beings have integrity, the equipment also do have. It's important for both to maintain the integrity. If there's a breach of integrity, then of course there will be problems. So next is tube size, the connections. Unless the connections are appropriate, you have checked and you have kept ready, it will be difficult to do the same thing once you start the airway management. Then the tube size, very important, and the point number 1 and point number 5, they go together. Size selection is based on the tube size that is appropriate, and tube size is dependent on what size you have or we have chosen. So basically we'll see that. So 1 and 5, they go together. Okay, then accessories and attachments. You see, there are so many accessories which can be used for the benefit of the patient, along with the flexible video endoscope. I just shown you in a slide at the end of the presentation. Then the procedure, which I'm not going to describe in detail, just mention a few steps. Then the disinfection storage. So first step is, when you choose the size, you should remember that the size of the endoscope should be at least 1 size smaller than the 1 or 2 sizes smaller than the endotracheal tube. The fact is that the tube should be able to move like along the insertion cord easily without any friction. Of course, there should not be too much of space also. So a reasonable space between the insertion cord and endotracheal tube, on the one hand, prevents damage to the scope. On the other hand, it also helps you to smoothly railroad the endotracheal tube over the endoscope, which is a very critical step once the scope is inside the trachea. It should have been, you must ensure that it is properly disinfected. Then inspect for physical integrity, and say when you inspect for disinfection, see whether there is any physical impurities stuck to the scope, some protein, some material, secretions, etc. And the physical integrity, yes, you do a suction. There's a pressure gauge, especially for the fiber optic scope. The question is not very important in the modern scopes. You can pressurize that and see whether there's a leak. If there is a leak, then we should not use if it is like badly leaking, because once you leak and use it, it can worsen. It's like a vicious cycle. It can worsen very easily, and repair can be very expensive. And unfortunately, I do not have the picture. You can see on the monitor all the dark spots, black spots. If it is damaged, it's very easy to identify. So then check the ease of movement with the control lever. If it is not used for a long time, if the mechanical parts are not moving properly, then you may not be able to intubate smoothly. Then check suction valve and the knob by pressing the knob and attach the suction. After attaching the suction, then check and attach and check the light source. It's not check and attach, sorry, attach and check the light source for proper working, and then focus if it is required. So this is how you hold and press the control lever, and this is how you hold the tip of the endotracheal tube. So here it's loaded, and here you can see the light already, it's illuminated, or rather the connected to the light source. You can see the suction a knob or button, what do we call? This is the control lever, pressing up, backward movement, pressing down, forward movement. So control lever and so this is the same. You see the suction is attached. This was this scope we used for a long time in case today, the eyepiece and the adapter ring. And this is for just camera attachment. And then this is how you should not use it. This is how we should use. The bend should be here. You should not bend the insertion cord, especially if it is a fiber optic cord. And here again, you see the various movements, and then this is what we see when you pass it in a proper place. Only thing is here you can see it's almost in the center of the screen. That's very important when you do a endoscopy to ensure that the image is in the center of the screen. This is how the epiglottis is seen, the glottic opening, tracheal rings, the carina. These are the important structures what you aim. So you must have a mental picture what you expect depending on your assessment. Are you going to encounter any resistance at the nasopharynx level or even before that? Or are you going to encounter some resistance in passing the tube, the scope beyond the glottis? Things like that. Or could it be the railroading? So here again, you can recognize, and the flexometallic tube is used in this. You can use any type of tube as long as you know what you're doing and why you are doing that. You can see this is how it should be held taut. That's very, very important. So initially your hand fatigues, and you see the other side, you can give other nostril, you can give oxygen also, or you can give oxygen through the scope. So the working channel is meant to give spray as you go, or you can use a epidural catheter and spray through that, or you can attach oxygen. So these are, or for a retrograde intubation, again, you can pass the epidural catheter coming, or the guide wire, the thin guide wire coming from the trachea proximally. You can pass it through the distal port or the tip of the insertion cord and retrieve it at the proximal end of the working channel, and then advance the scope over the guide wire. So this part, I'm not sure how much TPGs understand, but that's fine. So just focus on this, that the different types of, here you see it is stabilized with a tape. There are endotracheal tube holders also available which fit into the connector. So this is gently, millimeter by millimeter, you go, keeping it straight and taut, identifying the structure, keeping the image in the center of the monitor. So do oxygenate the patient well, means take care of the oxygenation as the priority number one. Be gentle with your technique, identify the structure and confirm the placement, and then pass the endotracheal tube. And don't bend the insertion cord inappropriately and acutely. Don't use damaged scope. Don't use too tight fitting tube. Don't use force to push in or pull out. Both are important. Sometimes what happens is you intubate with so much of difficulty. You want to take out the endoscope. You are not able to pull it out. So best thing is to, or what is recommended is to take out the entire assembly. Even if you think that your effort is wasted, you will not damage the scope or you will not damage the patient's brain. So that is what is recommended. Okay. So then now last few slides, the accessories. These are the airways, oxygen, epidural catheter, local anesthetics, etc. So to guide or facilitate intubation, to administer the local anesthetics, or as a part of the plan how you use them. So this is the Ovesipian airway, this is the Berman airway, this is the CMAC. The hybrid techniques are recommended in certain types of difficult airway. Suppose you can't pass it from the nose at all, or with multiple attempts, you are not able to identify, you are not able to pass the scope, and you are able to ventilate the patient. Patient is under anesthesia. Instead of struggling for a long time, you can use a video laryngoscope to expose the glottis, then pass a oral FOB or the flexible video endoscope and intubate the patient. So that's one of the hybrid techniques. You can devise your own hybrid techniques. Epidural catheter for using this spray-go technique, or this is an air cube mask. So it's recommended for intubation. You can intubate with, if you remember the IDA guidelines also, when you intubate through a supraglottic airway device, it is always recommended that you must use the fiber optic guided or the endoscopy, flexible endoscopy guided technique for intubation through difficult air. So this is through classical LMA, because you cannot directly pass the endotracheal tube. You do a two-stage technique where you initially pass the entry catheter. You can see the entry catheter here, or you can pass a bougie also over this, and then you take out the laryngeal mask airway. Then you pass the endotracheal tube, 2 or 3 stage technique. So just to summarize, FOB, as it is commonly called, is a versatile equipment, needs training and careful handling. Any equipment, of course, needs a respectful and careful handling, can be used for multiple indications in multiple ways, fiber optic and non-fiber optic, the composition and the disposable and purpose made like ICU or things like that. And just to introduce you, this is our forthcoming book. The cover page will not be like this. So it's called Anesthesia Residency Manual. This is a book aimed for residents only, how to make the best use of your residency 3 years, starting from day one till you pass out. The step-by-step sort of some thoughts about how you can make, like patient, whether it's about patient care, your own success, your own excellence, or how you can the ethics, morality, how to face the exam. So all these things are covered. I hope all my dear friends and colleagues and residents will support or will welcome this new venture. Thank you again, Dr. Shripad and team, for giving me this opportunity. I enjoyed the session. Thank you so much.
Thank you, sir. It was just listening to you a few years back, the same feeling, and so well spoken and so explicit understanding of the equipment and the transmission of the same knowledge to the people, listeners. If there's any questions, please, you can put it in the chat box or you can ask it directly now.
Also, you are requested to give feedback.
Your feedbacks.
On the link provided in the chat box.
Ravindra sir, thank you for joining us.
Thank you.
Looking forward for your anesthesia residency manual.
Thank you.
Congratulations on that, sir.
Thank you so much. Yeah.
Dr. Ravindra, when is the launch of this book?
I think maybe 2nd or 3rd week of March.
Great. We are looking forward to
very soon. It's a print ready now. Just the process is pending.
Great.
Just no, ISBN number also is going to come soon, and it will come out very soon. But this is not the front page. That's all. Okay.
No, that also looks good.
But it won't be. Thank you. Okay. Yeah.
Thank you, sir, for joining us.
Excellent discourse on fiber optic bronchoscope. As fresh and as simple as ever, Dr. Ravindra discourses any topic. Thank you so much for joining us.
Thank you for all the kind words. Thank you.
Yeah. The end of this session, I would like to call upon Dr. Govindraj Bhatt to give the vote of thanks. Over to you, Govindraj.
Hello.
Yes, we can hear you, Govindraj.
Yeah. Good evening, one and all. It gives me immense pleasure on behalf of Department of Anesthesiology and Critical Care, Nitte deemed to be University, to convey the vote of thanks for this program, Nitte Anaesthesia Education Series. Let me first of all start by thanking Almighty God for making today's program a resounding success, with the participants from different medical colleges and hospitals who have registered. I thank our special guest, Dr. Rama Subramanian Krishnamurthy, who was gracious enough to step in for Dr. Suresh Rao KG in the last minute and delivered a wonderful talk, that is our masterclass on cardiac electrophysiology, conduction system and ECG. We thank you, sir. Next, my heartfelt thanks to Dr. Rangarajan N and Dr. Sanish PJ, who moderated a very dynamic case discussion on patient on pacemaker coming for incidental surgery. It was a very interactive session. I thank you, sirs. My sincere thanks to both the postgraduate students, Dr. Komal R. Deshpande and Dr. Harshita MG from ESI Postgraduate Institute of Medical Science and Research, Bengaluru, for their active participation in the case discussion. Next, equipment of the month, fiber optic scope, was taken by my very own guru, Dr. Ravindra US, who actually also taught me the fiber optic bronchoscope and gave me the first chance when I was a postgraduate student under his guidance, who taught me how to use the fiber optic scope and on all the difficult airway cases. So he made this topic so interesting and very simple and elaborate. And I'm sure the PGs have benefited from his talk. Thank you, sir. And it was our indeed pleasure to have you in this program. Thank you, Ravindra, sir.
Thank you.
I thank all the delegates who have registered for this event and have actively participated. Thank you, delegates. Lastly, I would like to thank our beloved head of the department, Dr. Sripadji Mehendale, Dr. Sumalata R. Shetty, Joylin for the welcome address, and all professors, department colleagues, and postgraduates for their contribution towards the success of Nitte Anaesthesia Education Series. Now we are on the 7th loop. I would like to thank the IT department, Nitte, deemed to be university, for providing all the support. Thank you, one and all. Over to Sripad, sir.
A big thanks to you, Dr. Govindras Bhatt, for being there with us throughout and for this delivering of vote of thanks. Thank you.
Thanks everyone, especially my old friends, Dr. Abubakar, Dr. Himalata, Dr. Alvina, and many more who are with us. And a special thanks to Dr. Ravindra, who has joined from Brunei and the late night.
No, not late night. It's
Not late night.
It's around 8 o'clock.
Okay.
8:15.
Your dinner time. This is the right time to be participating, I think.
Yes.
Yes.
Actually, just reached home today after quarantine. Thank you.
Oh. So you had a quarantine in Brunei, is it?
Yes, hotel quarantine, 6 days.
Oh, yes. Okay, thank you so much. Thanks to all my friends, colleagues, and all the delegates, and Nitte for a great support. And next month we are going to come back with the 8th episode of this Nitte Anaesthesia Education Series related to cardiac anesthesia with another set of great speakers like Dr. Ravindra. And we look forward for the book, and I expect all our residents to go through the book and imbibe the essence to progress more steadily. Thank you so much. Thanks everyone. Thanks Joylin and Govindraj and Dr. Suma for this special program. Thank you so much.
Thank you.
Thank you.
Yeah.